Good afternoon. I'm Dr. Andrea Chisholm, Deputy Director and Chief Development Officer of the Trust, and I'm glad that you're able to join us today for the third webinar in our Business of Practice webinar series titled An Applied Overview of the 2024 APA Guidelines for the Practice of Telepsychology, Updates and Implications for Practice. Presenting today's webinar is Dr. Jonathan Pearl. Dr. Pearl is a board-certified child and adolescent psychologist, associate professor, and director of telepsychology at West Virginia University's School of Medicine. In addition to his current responsibilities that include trainee education, specialty clinic management, and conducting research, Dr. Pearl provides both in-person and digital psychological care. Dr. Pearl also has been recognized as a psychological innovator by the American Psychological Association's Monitor for his work designing an evidence-based and HIPAA-compliant smartphone application related to parent management training. I hope everyone learns a lot over the next hour. Now, Dr. Pearl, it's all yours. Please join me in welcoming Dr. Pearl.
All right. Well, thank you very, very much for the introduction. Excuse me. First things first, a sincere thank you to the Trust for inviting me to speak about this topic. I know you guys can invite a lot of different people, so I appreciate you thinking of me. And I really, truly do appreciate everyone coming out to hear my presentation. I know it can be very difficult to get away from clinic or your job or whatever you might do. I know for me, just getting away for 10 minutes is difficult. So getting away for a multi-hour presentation can be difficult. So I really, really do appreciate you coming out to hear me talk about this, namely an applied overview of the 2024 APA guidelines for the practice of telepsychology. Title rolls off the tongue, right? I wanted to make sure it's descriptive because really today we're going to take a deeper dive into the 2024 guidelines. And as cliche as it sounds, I just want you to know where I'm coming from. Of the guidelines is really, they are a culmination of everything I've been doing for the last couple decades. When I was in graduate school, and for those of you who know me, I was studying and teaching about and using telehealth and different digital technologies for a very long time. And I literally could not find someone to supervise a dissertation or to supervise work when I was in graduate education. So much so, I almost couldn't do my dissertation and had to switch schools. And I was very fortunate that I met a supervisor who I've stayed friendly with, and we published quite a bit together. But it's interesting how things have changed over time, right? How we went from this is, I was told it's a very stupid idea. It's never going to take off, and it's never even going to be comparable to in person. There's just a lot that's lost in that translation. And things have changed quite a bit over time. So I for one, find that quite interesting. And I'm glad I stuck with it because it is something that has become a new norm. It's ubiquitous at this point, it's everywhere. And as we're going to talk about, it's become an expectation both among the providers, the practitioners, and among the patients. So with that said, before I get into it, I just want to make mention, I did supply a couple different handouts, some of which we're going to talk about as we go through, including a crosswalk that I'll highlight in a little bit. But one of which is a resource guide that I've been collecting information for over the years. I actually started it during COVID and it's kind of ballooned over the years. And now I think it's up to like 17 pages. Not all of it's going to be applicable, but I would encourage you to take a look at it. It's meant to be a supplement for what we're going to talk about here today. There's information on dozens of topics ranging from guidelines to informed consent to data security to training to testing to all kinds of things. And what I'm proud of is that it's not just United States specific. There's a lot of information cross country, information for Canada, Australia, and England, and just the EU in general. So there's a lot of good information, and I hope you at least take away one resource from that. So with that said, without further ado, when it comes to our learning objective today, these are at a minimum. I hope you take away a lot more. But at a minimum, I hope you identify at least two novel domains of the 2024 guidelines, discuss at least two ways in which the 2024 guidelines, the novel domains, influence one's clinical practice, and identify at least one additional resource beyond the 2024 guidelines to assist in your practice. I just got done saying that I gave you a multi-page guide on that, but we will also talk about additional resources here today that may not be in that guide. So I figured we'd cover it from multiple standpoints. Before we get into it, I do have a couple disclaimers up front. I was part of the team that created the 2024 guidelines. And while I have worked with APA, I give presentations for APA, I work with a lot of the members. I just want to say up front, I am not formally presenting or representing the American Psychological Association. And this is important because while I'm going to be going into detail on the guidelines we created, I'm also going to go off script a little bit, give you a little bit of some extra resources and information, and I will present some of my opinions and my research and my background as well as it relates to those guidelines. And if that doesn't make any sense, I think it will when we get to those sections where I say, here's my opinion of how we interpret some of this information that we present upon. Now, I think it's important to recognize that my job today is to provide an evidence-informed discussion that is as up to date as possible. But even in the time it took me to give that introduction, there's probably at least one or two new, legislative documents being introduced. In other words, telehealth broadly is rapidly developing and constantly changing. This is not just in terms of the research, but also regulations, data security, and a lot. So this is meant to hopefully help steer people, but it's not all inclusive and it's not exhaustive. So I would encourage people to keep doing their due diligence to make sure they remain active on this information. I will be doing my best to present both the pros and the cons of use as it relates to the guidelines, but I think it's fair to recognize that I am very clearly biased in one direction. Now, with that said, I do not believe that the use of telehealth or telecommunication technologies are for everyone under every circumstances and every possible situation. And I'll explain a little bit more about what I mean as we go. But I do think it could be adapted for a wide audience, but I think there are some rationales for when it may not be the best option, even though it's available. And I'm obligated to say that I am not providing ethical or legal advice. I am providing ethical and legal information. What you do with that information is completely up to you, but I am not a lawyer. I do not represent APA, so I cannot give you direct advice. And finally, I cannot answer individual practice or patient-specific questions, and I've also been instructed that I cannot provide very specific detailed information on insurance and billing. So I hope you understand. Also, as a final disclosure, I do in fact receive royalties for a book I wrote on telehealth. I am not hawking it. You do not have to purchase it unless you want to. But I will say that some of the information that we're going to talk about today, as well as some of the information that I brought to the guidelines, was from the research and the practices that came out of my own research, as well as my book. And like I said, I do receive royalties if you do decide to purchase it. So, with that said, enough of that. Today, what we're going to do is we are going to start our discussion by defining telehealth. Now, some people go, why? Isn't that something we've all come to kind of accept? We know what it is. Well, as I'm going to explain, telehealth is a umbrella term, or telepsychology is an umbrella term. It's actually far more complicated. So I want to make sure we're on the same page. We're then going to review telepsychology research outcomes, up-to-date research. I want us to make sure we're on the same page because that research and those processes ultimately inform the guidelines. We're going to discuss briefly, only a couple slides on the 2013 guidelines, so we see where we were to where we are. And then we're going to spend the majority of our time together really breaking down the 2024 guidelines one by one to talk about what the high points are, how you apply it to practice, and then some tips and tricks, so to speak. I have a couple slides on some problem solving and additional resources, and then I will do my best. I tend to talk a lot, if you can figure that out. I will do my best. I was told there's probably a lot of questions, so I want to leave ample time for Q&A at the end. And I should say up front that the way I broke this up, the first roughly third is really the background and building to where we currently are with the guidelines. And the final 2/3 is really breaking down the guidelines. So it's kind of that split. And I want to say up front that we could spend hours on any one of the guidelines. So today is really meant as an overview of the primary foci of these discussion points. And we're not going to break down each into individual kind of minutia because we just don't have time to do that. So like I said, with what we're talking about today, I would strongly encourage you, if you have an interest, take a look at some of the resources because it should help guide additional competency development. Okay, Now, I always like to thank the people. Promise I'm not going to read these, but I do want to thank the people who contributed to the 2013 guidelines, basically creating guidelines where they didn't exist. Linda Campbell and her team. And then I want to thank the 2024, especially Sarah Smucker Barnwell, who led the charge and really helped us organize this and get the ball rolling in the right direction. So, with that said, I always like to start with a very, very stupid question just to kind of frame our discussion. And I always ask this in person. I know this is video, it's a little bit different, but I want you to consider for a second who here practiced telehealth in any way, shape, or form prior to COVID-19? Who would say they're a telehealth provider before COVID-19? And usually when I ask this, I get a couple hands raised. Nothing major, but a couple hands. People go, not really. I didn't really do it a whole lot, right? Well, I want you to consider that if you are someone who says, I really didn't do it beforehand, how many of you ever spoke on the phone to a patient? Did you ever ask what state they were in or country they're in, what jurisdiction they were in? Did you ever collect information or give any advice? Because legally, even though it wasn't necessarily named that at the time, you were in fact practicing a form of telehealth. And I will say that almost every single person who was practicing prior to 2019 was practicing a form of telehealth, whether we really recognize it as not. And I hope I've been told to change the picture. I love this picture. I hope at least one of you recognizes this kind of phone. But my point is that if you were practicing prior, it's been many, many years, right? And times have changed. So the question then becomes, and this is going to be relevant to the research that then informs our guidelines, how old is this? Like, if we've been using it for that long, like, how far does the telehealth rabbit hole go? How long have we been integrating telecommunication technologies like phones or videos with healthcare services? 70s, 80s, some people say the 60s, maybe in the 40s, kind of the, World War II. Well, if you really trace it back, some of the earliest indications of the integration of telephone specifically with healthcare is actually in 1879. We're going all the way back. The Lancet, which is a respected medical journal, had a piece on how a physician was diagnosing croup via telephone. They were put the grandma or grandmama, in this case, it says, was putting the baby up to the phone so the doctor can diagnose it from a distance. Now, rudimentary by our standards, of course, but it was the first indication. And this continued into the 20s, 30s, 40s, 50s, where these are not comic books. These are in respected magazines at the time, including scientific magazines of the radio doctor or the teledoctoring with robots and with video. And while, again, the principles may not be identical, you can see this is a notion that was going all the way back that people were trying to do a long time ago. So what about mental health then specifically? Well, some of the earliest indications were from the Nebraska Psychiatric Institute in the 50s and 60s. They had a closed network system that had a video system from them to a local hospital where they provided not only medication consultations, but group therapies. So this is going way back. And further yet, it's not just a United States thing. A lot of the research in the books focus exclusively on the United States because a lot of the research and a lot of the examples came from there. But one of the other examples from our neighbors to the north, the Memorial University of Newfoundland's Telehealth Educational Technology Resource Agency, or TETRA, Dr. House founded this in 1977 using satellites to connect people not just for healthcare and hospitals, but also education on those processes. So this is going back a very, very long way. This is not necessarily a new concept, despite the fact of sometimes you see that in the literature. And I was just reading a paper in JAMA the other day, a Journal of the American Medical Association, that still says telehealth is one of the newest ways to see patients. And that's not necessarily true. So I think we have to put it in perspective. Now, if you're wondering why I'm giving you a history lesson, because you're here to talk about the 2024 guidelines, this is extremely important because telehealth in one way or another has been around for so long. This means that there are dozens of different definitions in the literature, in the law, and in the research of what the term telehealth means. And this gets more complicated when you throw in telepsychology, telemedicine, e-health, digital health. And in our case, Just the word telehealth alone has dozens of different definitions by the WHO and the CDC, HRSA, the DOD, the VA, the APAs, the AMA, the ATA. The list keeps going, all the alphabet soup that you can think of. And this includes in Canada, Australia, England, Japan, other places. We care because one of the good things, if there is such a thing, that came out of COVID was the proliferation of telehealth and the normalization of reaching people where they maybe weren't going to be reached before. However, one of the bad things is the proliferation of research that's a little bit, finicky. Journals they were trying very, very hard to get research out in response to COVID-19 that, in my opinion, and some researchers' opinions, the quality went down and the review went down. And the problem is a lot of journals were publishing papers that stopped defining what telehealth was. So why do you care? Well, we care because if we're trying to look at the research and we're trying to pull evidence-based practice and evidence-informed practices, we have to know what we're looking at, because sometimes telehealth only referred to video. Other times it included telephone, sometimes email or text. Sometimes it included virtual reality and AI. So it varied a lot. And I have seen papers and I've seen legal documents citing papers on how video-based telehealth is great when the paper only used the word telehealth and they cited it. When you look at the methods, they were only specifically talking about email and texting. So this is where we've had a lot of issues in the literature and in the field of trying to figure out what works for whom. And that was very important as we're trying to collect research for the actual guidelines. So this is the definition I like to use, where telehealth is an umbrella term. It's broadly the integration of telecommunication technologies with healthcare services. Telecommunication being phone, video, email, just that communication aspect. So it's limited to telecommunications. Doesn't include all the other stuff, nanomachines, robotics, that kind of stuff. Under that, you have your specialties. Two biggest, there are a lot more, but two biggest, telepsych and telemedicine. For telemedicine, you put the tele prefix in front of it and you got it. So teleradiology, teleendocrinology, telegastroenterology. For psychology or telepsychology, you not only have your orientations, humanistic and behavioral and CBT and feminist and dynamic and analytic and all that, but you also have subspecialties, teleneuropsych, teleforensic psych, teleschool psych, and the list goes on. But regardless of which specialty you're doing, in this case, we're going to be talking exclusively about telepsychology, we're doing either synchronous or asynchronous care. Synchronous services are live in real time, back and forth. You can answer in real time. You can clarify in real time. This happens predominantly through video and telephone. This is in contrast to asynchronous or not synchronous, sometimes called store and forward. This means that you can write them, store them, and send them at a later time, and they might be received or they might not, but you can't really communicate in real time. Emails, electronic health record in basket or MyChart messages, stored messages. These things are not necessarily sent in real time. Most providers now are doing a hybrid service, which is a combination of synchronous with asynchronous and in person, blobbing them together. So I'm going to see someone in person for a new visit. I'm going to see them for video for the most part with some in-person check-ins, and we're going to communicate via an electronic health record. The services that you can provide are broad, though. Besides assessment intervention, those are the ones everyone talks about. We can use telehealth prevention services to give education, consulting, research, training, supervision, data management, communication between healthcare professionals or schools or private agencies, and advocacy. We can do a lot with this. And finally, all of the blue historically had been done by desktop and laptop computers. But about 20 years ago or so, mHealth or mobile health, so think apps and tablets and smartwatches, became popularized. And now you can do everything with that little rectangle in your pocket. You can do all of this with just a smartphone. So, the times are changing, so to speak. So I hope that made sense. I just want to make sure we're all on the same page. So that brings us to, where are we in terms of the state of telepsychology? What does the research say? Well, I'm sure I'm preaching to the choir on this one, But telepsychology really grew from a technological advancement in clinical need. Now, when we talk about clinical need, like I said, I'm sure I'm preaching to the choir. We all know there is a significant need for healthcare and especially mental health care. This has only exploded over time. So while we were in need before, following COVID, we saw a rise of anxiety and medical illnesses and stress and depression and behavioral issues. Especially, I work with kids, so we see a lot of behavioral issues. So we have a need. And even about 15, 20 years ago, about 75% of counties in the United States were still considered mental health shortage areas. Now, granted, that lumps together psychology with social work, counseling, psychiatry, but we are in dire need. And while we have done better over time, we're nowhere near where we need to be. There remains a clinical need. And I really just want to mention for a second that a lot of the research and a lot of people I talk to still to this day, when you mention telehealth, they go, of course, you're in a rural state. Of course, you're going to use telehealth. Well, a lot of us, myself, obviously myself included, but a lot of the researchers and a lot of the field experts and a lot of the books and a lot of the guiding organizations, while they did initially really focus on rural, a bunch of us said you can apply a lot of the same stipulations to urban settings and urban individuals or suburban individuals. So in other words, the transportation issues, the getting off work issues, the financial issues, the child care issues, or the adult care issues, you can apply a lot of those across the board. You don't have to be in a rural area. So before I moved to West Virginia, I was in the Chicago area, and we used to work with people who, let's say single parent, two kids, couldn't get time off work, no FMLA, would get fired if they do. So they have to come see us before work or after work, meaning they have to go in rush hour. An hour each way, because let's call it what it is, psychologists are not in the settings where most people need them. We're in the business centers or the downtowns or the hospitals, those kind of things. So it's an hour roughly each way on a good day, considering traffic, an hour for the session. Plus, either I have to pay for gas money and you could pay for parking, which could be up to $40, or I could take public transport, still pay, and it may not be on time. Plus, what do I do with my children if I'm not bringing them or I have to get them off school? So you can see this can preclude even the most well-intentioned people from getting services. So how are we supposed to reach these people? Well, tech became smaller, more powerful, more readily available, more interconnected, greater speeds. It provided an outlet for us to be able to reach a lot of these people, both urban and rural, regardless of the stipulations. We can reach people. So this was very, very important. So do people want it? That was the $1 million question. And I used to have research here and I dumped it. I just put pictures up. We have CVS and Rite Aid. You can throw in there Google, Walmart. These multi-million, or in some cases billion-dollar companies would not be putting millions of dollars into systems and kiosks if they were not going to see a return on investment. Now, we're going to talk about this in a moment, but there is some truth to the notion that during COVID, most people were forced to do a form of telehealth and not everyone liked it. That is a truthful statement. Not everyone liked it. When the stay-at-home orders were alleviated, were done away with, most medical professions, the telehealth numbers went way down. Now, they're still relatively high. Don't get me wrong. They're still above 50%, but they went way down from 100%. The only field that remained very, very high, psychology. So we have a need. There is a patient desire for it, and we have systems being set up across the board to help manage this. So we do know people want it, and there's financial support for that. So the next question is, does it work? Well, yes, it is used, and yes, it does work. However, there's a asterisk with a blinking light under certain circumstances. Now, I give literally 3 to 8 hour trainings on just that topic, so we don't have time to go into all that. So all I'm going to say right now is we are not going through all the logistics, and I'm not going to go through how to adapt it per se, because you have to adapt your speech. You have to adapt the environment, how you're talking. You have to take more breaks and pauses, because if two people are talking and you're using video, a lot of the video systems will cut one person off and you might miss information. So you have to learn how to kind of talk and pause, just like if you're using a translator. Setting up the room, which we'll talk about a little bit later, we get to the guidelines, have to be set up in a certain way because room setup has been found to be a causal outcome or a causal factor of positive outcome. So there's different things you have to know. But we're not going to talk about all that. The question is, does it work? If you make proper adaptations, and that's the key phrase there, you can't just take what you do in person and translate it as a one-to-one and it works perfectly. If you adapt it, yes, it can be extremely powerful and work well. And we know that because when you look at meta-analyses and reviews, there are enough well-designed studies out there that have consistently found the same outcomes to warrant guiding organizations like the American Psychological, American Medical, American Telemedicine, American Psychiatric, HRSA, the DoD, the VA, to all come to the same conclusions that they could be positive. Now, there's always at least one statistically minded person in the audience, and I feel you. I had the same arguments on this that meta-analyses and reviews can say whatever you want depending on what papers you pick, and they're only as good as the papers they're made up of. So when you go backwards and boil it down, both the smaller and larger scale studies, including the randomized control trials, which are often considered the gold standard for establishing things, there's enough there, and it's enough consistent evidence to suggest, yeah, it can be helpful, even though the research is still considered in its infancy, broadly speaking. And I think it's fair to say that when you compare the amount of telehealth related research to that of a medication, most medications don't have that much research. So again, you have to kind of take it in the vein that it exists in. But what does the research say? Well, it says that telehealth, broadly speaking, can be helpful for both urban and rural places. I mentioned that. Outpatient hospitals. And there's been a push over the last, 5-10 years, really talking more about schools, corrections, teleforensics, that kind of stuff, and assessments for that matter. I'm not going to lie. In the 2000s, a lot of the research, including a lot of Northwestern, was on telephone. And we found that it can be very helpful, including for anxiety, depression, a lot. Really, in the 20-teens going into COVID and in post-COVID, the vast majority of the research is, in fact, on video. And a lot of people really go, that's where I stop, and they write off emailing, messaging program, text, chat bots, those kind of things. Now, let me just say up front that it is true. The vast majority of research for email and the asynchronous methods, messaging programs, and a lot are not as, the outcomes aren't quite as good as video or telephone, the live synchronous stuff. But I wouldn't write them off, and a lot of people write them off. There are a lot of self-guided programs or a lot of chat-based programs for substance use, for suicide, for abuse. This includes in the United States, Brazil, Israel, and other places. And they've been found to be quite helpful either as a standalone intervention or as a stopgap to make sure that person is safe and has some intervention so that they can then go into either video, telephone, or in person. So while there is some truth to they may not be as powerful or as solid as some of the other interventions that are synchronous, doesn't mean they can't be helpful. Conditions. Just looking at it from a historical perspective, initially, if you really trace this back, you can find that people go, telehealth ain't going to work. You need in person. It's just not going to work. You lose something. We studied it. We found, yeah, it's okay. Well, it's probably only going to work for the worried well. It's not really going to work for pathology. We studied it. We found, yeah, it can work for pathology. And the list keeps going. We started with anxiety, depression. Well, that's okay, but it won't work for the real challenging stuff. Trauma, eating disorder, complex OCD, or treatments by proxy, such as parent management training for disruptive behaviors for kiddos. And again, when you really go one by one and you look at the research, most conditions have been found to be helpful, with, again, the caveat that adaptations have to be made. And it's not for everybody. There is research out there that looks at psychosis even. And while they found some positive outcomes, again, it depends on where the person is in treatment, what their awareness is, medications, the whole 9 yards. So there's a lot more to it than just does it work or not. But again, can it be effective? The answer is yes, at least according to the research. And as I mentioned, this is not just for assessment intervention. Refills, supervision, consultation, it can be used for lots of different things. So let's go back. So we know there's a need We know people want it. It's worked. When they use it, how do they feel about it? Well, all the research says the same thing. Before people used it, they were highly skeptical. That includes the practitioners and the patients and their families. After use, there's pretty much unanimous, yeah, it's okay. No major issues. And if there are negative opinions of it, most of the time, there are just some people who do not like it, and that's okay. Not everyone has to use it. Totally fine. But if people do not like it, it's usually because of the tech itself and not the service. So, what do I mean by that? Call drops, bad video, bad audio, lots of reconnections, power goes out. So, they don't necessarily dislike it, they dislike the surrounding logistical factors. And if it works, generally speaking, the satisfaction is quite high for the patients, their families, and for practitioners. So you have to take that with a grain of salt because, quite frankly, I don't like it either when the power keeps going out and when the video is not very good and my patient's getting angry with me. And I don't make the video, of course, but we have to use certain systems. So it annoys me too. And I'm a big proponent of it. So I can only imagine if you're not a big proponent of it, how you feel. The biggest question that came out of this, and this was one of the reasons why people were skeptical it doesn't work at all, is what about the therapeutic rapport? And there are enough well-designed randomized control trials across different times, across different conditions, across different treatment types to suggest that if you make necessary adjustments, therapeutic rapport can be equal or comparable to in-person. Now, this depends on a lot of factors. And like I said, we're going to talk about a few of them when we get to the competency areas. But again, we're not talking about how, we're saying can it be? And the answer, at least quantitatively and qualitatively, has been found to be yes. It can, in fact, be quite useful and rapport can be established. All of that is really, rainbows and butterflies. Everything is very positive. I'm trying to paint a positive spin on it, but it is not all rainbows and butterflies. It creates a wealth of new practice, ethical, legal considerations, as well as possible issues that could come with it. And as with any new development, we need to make sure there's additional training and education that goes into it because I hear all the time, and I still hear this. I hear this from my students all the time. I am really good at computers and I'm really good with technology. I use TikTok all the time. I have my phone, I have my tablet, I have my smartwatch, I have all this stuff. I know how to fix things. I'm really good at technology and I'm really good at therapy and psychology. This is going to be easy. And it's true, while you may have a leg up over someone who's not as used to technology, the problem is you don't know what you don't know, and it could create a wealth of issues along with it. So we need that education and training. And if anyone's wondering, I've been kind of vague on where some of this stuff is happening. So everything I just said on this slide is not unique to just the United States. These are international findings. We find the same things in terms of likes and uses and utility and rapport across Canada, Australia, Brazil, England, Italy, South Africa, India, Israel, China. You can throw up here Japan and a bunch of other places. We find consistent findings among many, many different countries across the world. So while this is not, of course, ubiquitous across everybody, it is pretty well defined and pretty solid in terms of the research. And of course, there's always individual differences, but broadly speaking, this is an international finding that has been found to be very helpful. And again, is it continue to be used? Well, according to a 2023 APA survey, and this is just one of many surveys, 2/3 of psychologists surveyed by the APA continue to offer telehealth services to some degree post COVID-19. So that's a lot, roughly 66.66667% are still using telehealth. But what I find more interesting than that is that 1 in 5 roughly are exclusively virtual. They are only doing a form of telehealth, which is usually video only. Because not all states, like West Virginia, for example, is a state, we can't do audio only right now. We can't just do telephone exclusively. So when we talk about virtual, most people are doing video. But that means, 2 out of 3 are offering telehealth, and then 1 in 5 are offering just telehealth. So this is not something that's going anywhere anytime soon, even if people are not thrilled about it. And again, a lot of people have come to expect it as a straight up expectation, for good or bad. And we can talk about good or bad, but um, it is an expectation. So it's something that we have to be aware of and, evolve with the times, so to speak. So that's why I appreciate you all being here. So that brings us to the ethical and legal practice of telehealth or telepsychology. Where are you supposed to look? Well, this is a screenshot of the listservs where everyone's just kind of pointing at each other. A great movie, by the way. If you haven't seen this, the Spider-Verse movies. But I love the picture because it basically just everyone pointing at each other. And when you look at the literature and when you read listservs, and I'm sure at least one of you can say you've seen this, when there's an issue or a question, everyone kind of points to each other, and you get a lot of, well, I did it like this. And then people go, okay, well, if you did it, that's okay. The problem with that is doesn't mean the person did it in an appropriate way. And I've seen a lot of questionable things as well as, downright illegal things, to be honest, some recommendations that could get people into trouble. And I'm not bashing anybody. I'm just saying, as a factual statement, some of the recommendations I've seen in the listservs or even in the literature have been kind of questionable at best. So the problem is because of this, a lot of people have referred to the telehealth literature and practice as the Wild West. And because there's no real guidelines, people were doing what they wanted for a long time. And when we look at COVID specifically, most of the fines and the regulations were put on hold a little bit to ensure continuity of care. We wanted to make sure people were getting care while everyone got set up. Well, most of those have dried up. The vast majority of those, waivers have dried up, but we still have fragmentation of the literature. We still have fragmentation of the law. So what are we supposed to do exactly? Where are people and psychologists supposed to turn to be able to get this information? Well, that's where we got to our APA guidelines for the practice of telepsychology in 2013. And when these were published way back when, which is crazy to say they're over 10 years old, which at least to me, it sounds like they're not that old, but they're over 10 years old. They had the guidelines hosted, and the American psychologists also published the guidelines. So people were able to get it in multiple different ways. Now, these were developed by the Joint Task Force for the Development of the Telepsychology Guidelines for Psychologists, and it was informed by the APA. So there was members from the APA, the Association of State and Provincial Psychology Boards, or the ASPPB, and the APA Insurance Trust, or APIT, which is now just the trust. So what this means, because I've heard some criticisms of this in the past, that it wasn't just a group of psychologists broadly just kind of saying whatever they want. They put a lot of thought and detail into this, and this was a collection of individuals from APA, ASPB, and insurance. So they were trying to cover the broad spectrum, not just how do we practice ethically, but what are some of the legal considerations, as well as some of the factors that need to go into, they call it CYA, covering your behind, basically. So there's a lot of different information going in this to make sure that we are doing our due diligence and guiding people in the right way. So these guidelines were translated into 8 core guidelines. And I know it's a lot of words, so let me just help you out a little bit. These are the high points in red. What they said is that psychologists who provide telepsychology services strive to take reasonable steps to ensure their competence with both the techs used and the potential impacts of the technology. In other words, it is not enough to know how to use the tech. You have to know how it influences your treatment, influences the patient, how you adapt it, how you problem solve and troubleshoot, how it factors into assessment, intervention services, and the lot. You got to know the ethical and professional standards of care and practice are met at the onset. This is not something you should go back and we don't want a whoopsie. You want to make sure you're doing well up front. Part of that is obtaining and documenting informed consent. Not just that you're documenting informed consent for the treatment, but the telepsychology specific services. And as part of this process, you're making sure you protect the confidentiality of the data, and that includes having proper security measures in place and disposing of any data and information technologies used in a manner that facilitates protection from unauthorized access. People who shouldn't have access don't have access. They had a guideline unique to the testing instruments and assessment approaches to maintain the integrity of them and maintain the fidelity of them. And then finally, be familiar with the relevant laws and regulations when providing telepsychology. Now, When we look at the original guidelines and you compare them to the 2024 guidelines, you can see they are substantially shorter. And that is not meant to be a knock against them. I know a lot of people who wrote them. I think they did an amazing job. But I think that's reflective of the fact that when they were brought together to create these guidelines, there just wasn't a whole lot out there. Like there wasn't as much research and guidance as there is now, and they had to make do and put their collective expertise together to be able to write these. And one of the biggest criticisms, and I have been equally as guilty of saying this, is that a lot of the guidelines were saying, do this, but didn't necessarily say how to do that or where to find that information. So practice ethically or practice legally or document informed consent. Okay, how? Like, what should I specifically do that's unique to telepsychology? And that's really where we ran into some trouble. Now, the good news is that a lot has changed since 2013. So, where are we at in terms of competencies that we then adapted to go into the 2024 guidelines? Well, I have good news and I have bad news. The good news is a lot has changed. The bad news is the research on it is rather limited. And I am not saying this as a kind of broad, kind of condescending statement. What I'm saying is when you look at reviews, you see the same things over and over again. You see that the research is limited. A lot of the research, when it comes to telehealth, especially as it relates to education and competencies, was really published by a few people, with those same people being cited over and over again. And when you look across healthcare specialties, so forget psychology, when you look across medical, counseling, social work, PT, OT, dentist, speech, all that stuff, you see a lot of repetition across the healthcare specialties, but you also see a lot of fragmentation. Some groups emphasize this while other groups emphasize this. And like I said, this is not just me talking and saying, oh, I'm biased. My team and I, we literally just had the paper accepted and published on Friday. And I cited it at the end if anyone's interested. You don't have to read it, but we did a scoping review of almost every technology we can think of across almost every healthcare field we can think of. It yielded over 10.5 individual articles, and we narrowed it down to 109 that met our criteria. And while that sounds like maybe you did something wrong, no, what we found is that when we had criteria of you state a competency, it had at least one statement on it. Like, I studied ethics, including informed consent. Good enough. And we found 109 because most papers really did not go into any level of detail other than saying you should know ethics. So when I'm saying the vast majority was by a few people, yeah, a vast majority was by a few people. So when we boil down the papers that I think are most important, I guess you could say, that really have some level of detail and are heavily cited, that's why I picked them, this is kind of what we came up with. Now, this is an abridged version. There are more than this, but I wanted to highlight a few things. You can see here, and these are my naming, but you can see that there's quite a few domains or competency areas that are in agreement here. So those that have at least 50% agreement, you can see there's quite a few things that field experts are suggesting are needed when a practitioner is going to be practicing a form of telepsychology. So I want to break these down for a second because these are going to be very important when we talk about the guidelines. The first three really go together. So we have our technological components, our evidence-based factors, and our problem solving of the tech issues. When it comes to the tech components, we're really looking to the literature and the research and the guiding organizations and the experts to say what works for whom, under what circumstances, and with what adaptations. So we really need to know the evidence-based factors that go into it. So for example, video may be great for a Caucasian, 18-year-old female with anxiety, but not as good for a Caucasian 18-year-old with schizophrenia. Or telephone might differ. Or if we do a different race or ethnicity or population type, pathology or technology type, these vary. So just because phone has been found to be helpful doesn't mean email is equally as comparable. So we have to consider that in line with the research. So we have our tech components, but the tech components is not just what to select, it's also what factors you want. If I'm using video, let's say, do I want a digital waiting room? Do I want people to be able to fill out forms while they wait, or listen to music while they wait, or hear or watch videos while they wait? Do I need a video platform that can house X amount of people for group therapy? And if I do I have controls to kick people and monitor if I need to keep the peace, so to speak? Do I know how to problem solve the tech if it goes bad, let's say? And this is not literally problem solving, but also, can I convey the problem solving from a distance to someone who may not be in my office? Because if we can't connect via video, they can't see what I'm talking about. So can I convey that via an email or via a text message or via telephone? Or can I make how-to guides? I'm a big believer in how-to guides with screenshots of click here, do this, do this. So if people have no idea what I'm talking about, they can go through it one by one, or tutorial videos can be helpful. But granted, those take time to create. So, but these are factors that have been found to be extremely important if you're going to be using this practice. Clinician factors. This is not just the three I mentioned of knowing what to select and having the knowledge of the research and the practice to be able to do it, but it's also monitoring your own biases. And telehealth is not for everybody. I'm just going to say that out loud, that I work with people, even here, who are amazing. I would trust my kid to them or my family member with them if they're an adult. But I can see an overt difference of they just really do not like telehealth. They don't like video. And when they're in a room with somebody, they're lit up. And on video, the sessions are shorter. They don't explain as much. They're less enthusiastic. So knowing your biases can be very, very helpful. I don't mean in a bad way. I just mean some people are not, they don't like it as much. So, and it shows, even if it's not an overt factor that I'm trying to do this, because I don't think they're doing anything on purpose. I just think they don't think it's as good and they really want to get back to in person. In addition to clinician, we have our patient factors. How do the patients like it? What are their opinions? What are their past experiences like with technology? Do they like tech or not? If they don't, have they tried telehealth before or telepsychology before? If they have, they didn't like it. Why not? Was it because the provider never showed up on time? Was it bad connections? Because we can fix those things very easily. So, do people have the tech at all? People often, when I say this, they roll their eyes, but it is true. I'm originally, some self-disclosure, I'm from Miami, Florida. I grew up with lots of different people, lots of technology, and I've lived all over the country. Currently, I live in a very rural state. So if I was in Miami, maybe wouldn't have as much of this conversation, but I work with people who still have old flip phones from 20 years ago. I work with people who still have old desktop Mac computers. And while one could argue most people statistically have high-speed internet and some form of technology that works, not everyone does, and not everyone can afford it. So we have to kind of take that into consideration. Legal factors, I think this is the one that goes without saying that everyone is kind of familiar with. Having a license, making sure you practice in your own jurisdiction. Ethical factors, that's kind of what we're talking about, these two today, including informed consent, including evidence-based practices, and the rest of them. Telepresence, video specific, super important. It's been defined in a lot of different ways, but in a nutshell, at least the way I like to explain it, virtual eye contact, simulated eye contact. That means I position the camera so that when I move the person, their eyes are up here, so that when I look at their eyes, it looks like I'm looking into the camera, so that it looks like on the other screen, I'm making eye contact with them. So it's simulated eye contact, even though I may not be. What if you can't do that? Well, we found that even if you move the camera, so if I have it down here and I have my electronic health record up here, so I'm talking to you, I look like this. What happens is that we know this is a causal factor of rapport building. Even if I tell people when I'm looking away, it doesn't mean I'm not listening. People still rate it lower than if I was looking up here, even if I really wasn't paying attention. So telepresence has been found to be very important. And it's been, like I said, it's been defined in many different ways, but that's the most important factor for right now. Administratively, this is not just literally setting this up. Administrative factors also include billing. And this one gets a little bit complicated because what do you do in the case of an emergency? What if the power goes out? We just had an impromptu out of nowhere 65-mile-an-hour storm that blew out power for half the city or half the town, I guess. Can't really predict that because the weather people didn't predict that. So if the power goes out on my end and the person's not going through insurance and it's self-pay, do I still bill for that? If it goes out on their side, do I still bill for that? Well, I've heard both sides of the argument that if the power goes out on my end or your end, can't really control. It's not your fault, not my fault. I've heard an equal number of people go, yeah, listen, I don't feel good about this, but if I don't bill, I can't keep the lights on and pay my office staff. And that's part of the informed consent. I got to bill, and you roll the dice, or I bill half a session. Or if my power goes out, I don't bill. But if your power goes out or you can't connect, we still bill you. So I'm not saying what's right or wrong, but these are the factors that we have to consider up front, because I know some practices that got into trouble where they lost a lot of money because there's just too many people who were constantly having tech issues and they felt bad they didn't bill, and they actually had to let some people go because they couldn't afford certain things. So, and again, I'm not saying whether that's right or wrong. I'm just saying that that happened. Diversity consideration, what works for whom under what circumstance. Outcome monitoring. Outcome monitoring is not just does it work or does it not work. It is also how do people like it? How do you as the practitioner like it? If you hate it and it's causing you to have massive amounts of headaches, doesn't matter if it works, maybe it's not optimal for you as an individual provider, or maybe you only want to do half days. Or if you're a neuropsychologist and only want to do assessments, maybe it's not as optimal because we can't set it up to get what we need to do. Cost analysis, that's a huge one. Is the cost of buying the equipment and maintaining the equipment and doing all the rigmarole and getting the extra training, is it worth it from my financial standpoint? One could argue it probably is under most circumstances, but maybe not, right? And then interprofessional communication. We know what that means. On the flip side, ones that are mentioned but not universally accepted as, have to do's. Room setup I find really, really interesting because some research has suggested it as a causal factor for positive outcome. If you don't set the room up right, it actually influences people believing the sessions are appropriate, are good, and people don't put as much effort in, and it starts to get bad. So room setup means literally how to set up the environment to ideally mirror what would happen in session. And I can tell you all kinds of stories about not setting up rooms where I was consulting on this one, but a student was seeing a couple who kept doing therapy. They were doing couples counseling, and they were doing the therapy in their bedroom while they were laying in bed. And the student was so good that the couple, apparently after a couple sessions, started having, trying to be subtle sex under the covers on video, which was very much not appropriate. Or having, session while you're driving, that kind of stuff, not appropriate. But it's not just the physical area broadly, not having a window behind you so you're not one big silhouette, one big kind of shadow. Not wearing clothing that's going to be super loud or clanging jewelry, or I had some people wearing leather pants, because remember, you may not hear, but the microphone amplifies everything. So we have to keep that in mind. What about mirrors? We've had people where the room setup, the mirror reflected paperwork on the provider's desk, and it actually had some confidential information. And a patient was a little vindictive and angry with them, took a screenshot of it, and you can kind of guess where it went from there. So you have to be careful. And then mHealth and practice development. I am not of the belief these are super essential, but they have been brought up quite a few times. So with that said, let me just go back for a second. You can see all of these, right? There's quite a few here. So the takeaway and the message that we took into the 2024 guidelines is that telehealth is a series of competencies, not a singular competency. If you remember in the 2013 guidelines, it said you have to be competent. And what we considered is that there is no such thing as a competent provider anywhere in the world. It's impossible. Nobody is competent in medicine. Nobody is competent in psychology. There is no such thing as being competent in every individual possible aspect of every test ever, every intervention ever. And yes, I am being literal a little bit, but the thing is, the takeaway is that telehealth is a series of competencies that can vary by what technology you're using, what population you're working with, what intervention or assessment you're working with. So it varies by a lot of different factors. And it's unique to your practice. It's unique to one's practice, depending on what you do and what you don't do. So all of that, like I said, the first third or so was kind of setting up these guidelines. So now we're going to break down these 2024 guidelines. So I hope that was a nice introduction to kind of where we were, what work informs it, and now where are we going with it. So these 2024 guidelines, the process, just so everyone's on the same page, because I've heard some misinformation out there, that initially APA put out public comment asking, do we need new guidelines at all? And, it wasn't universal, but do we need these at all? Are the 2013 ones good enough, or do we really need to update these to make sure we're changing with the times? And public comment was pretty much on the same page that, yeah, we really have a necessity to update these things because while they're helpful, some of the statements are just not the same as they were in 2013. They're a little bit outdated. And there's a lot of new stuff that has come out that really is not touched upon or not touched upon enough to really give guidance on what to do. Because again, things have changed with all those competency areas that we just discussed. So APA put together what they called a diverse panel of subject matter experts. When I shared the thank you page, you can see that our group was a little bit smaller than the original one. So it was 8 members, and very important, it wasn't just health service psychologists. While there were a couple of us, there were also non-health service psychologists, including members from the Committee on Professional Practice, by the Board of Professional Affairs, the ASPPB, and the lot. So there were people who were not just clinicians, but also people who do research and are educators and supervisors and consultation and legal representatives and the lot. And not only that, but we had members from APA, like I just said, ASPPB, and we had legal representation, and we had members from the trust on it. So we kind of try to cover all of the bases we could to make sure that the representation was there. And we were careful that while a lot of the discussions really did fall into that clinical territory because those are the people who are using it the most, we were careful to also include some discussions related to research and advocacy and consultations and prevention and that kind of stuff. We were trying to be as comprehensive as possible. So we revised, we consolidated many sections, and we expanded the guidelines. And this was informed not just by research, because that was important, of course, but also books and guiding organizations. And what we tried to do, as I mentioned earlier, is there's some really good stuff that's not from psychology or not from the United States. So we tried to pull applicable information or details that were expounded upon in the medical literature or social work literature, counseling, really from the past 25 years. It says plus classic studies. But in my opinion, the vast majority of the research is really from the last, 10 years or so, because that's where a lot of the information exploded from. That's where a lot of competency areas really derived from because they just weren't discussed as much back in the day, 25, 30 years ago. And again, I can say that a little bit more definitively because we just did a scoping review, a pretty massive one. And yeah, it does go back. There are some kind of older things, but they don't really go into detail on how to do it. They just say, we did it. It really wasn't a discussion on how to practice. We put out for public comment, got some feedback. We got some positive feedback, got some critical feedback, and we updated it. We submitted it for review by the APA Council. And from what I understand, just to pat ourselves on the back, it was one of the quickest and unanimous, almost, I think it was unanimous. Anyway, one of the quickest acceptances for guidelines the last several years. So they thought we did a good job. And what I will say is that one of the comments we got was it's a little bit too long. Well, the original document was almost twice as long. And we ultimately, APA did approve a guidelines that was a little bit longer than the page limit we originally provided with because we thought that we wanted to put some of the detail in to guide people. So take that for what you will. So we could have made, a 100-page document. We decided against it, of course, but we were trying to make it at least applicable and as an update to that 2013 guidelines. Now, before we break down all the guidelines and spend the rest of the time kind of breaking them down, I want to make mention of the aspirational statements. So This is a direct quote from the guidelines. This is a direct statement from the American Psychological Association. These are guidelines. The term guidelines in this document refers to statements that suggest or recommend specific professional behaviors, endeavors, or conduct for psychologists. Guidelines differ from standards in that standards are mandatory and may be accompanied by an enforcement mechanism. Thus, guidelines are aspirational or not intended to guide regulatory action. Okay, pretty direct. So these guidelines are aspirational. There's not really an enforcement mechanism, and they're not necessarily mandatory. Okay, so we've actually had some discussions among our team. I was probably one of the biggest pain in the butts about this, but my question to you is, are they really aspirational only? Well, they're aspirational by definition, according to the APA, but I want to propose to you something. For those of you who have seen, Linda Campbell and her team are revising the APA ethical code, which are in fact standards with an enforcement mechanism. If you do not practice according to the ethical standards, you aren't practicing default of that. And really, the ethical standards go along with most people's psychology license, like license to practice in your individual state, because a lot of the same things they're talking about are also enforced by the licensing board. Okay. Now, the old ethics, but also the new one, for those of you who've seen the update, there are entire sections devoted to technology, not just including telehealth, but there's a lot on telehealth specifically. And I don't know, I'm not pulling the exact verbiage, but the idea is that when you talk about technology, they say you should practice in a manner related to ethics and legal and data security and informed consent in line with current standards put forth by the American Psychological Association and other guiding organizations. Okay. So the ethical standards are saying you have to practice in line with these requirements that just so happen to be outlined in the 2024 APA guidelines for the practice of telepsychology that are aspirational. So what it says is if you don't practice according to those other things, you're in default of the mandatory standards. But then the guidelines are aspirational, right? So my point of this rambling and this soapbox is that I don't want people to get confused with this, because if it says they're aspirational, some people go, well, they're not mandatory. I'll do what I can, and I'm really not going to put too much effort into it. And I've heard this from different people. And that's true. You can. But if you're not following these guidelines that we put forward, you're really not practicing according to the ethical standards, and that can get you in trouble. If you're not practicing according to these 2024 guidelines for the practice of telepsychology, you're also likely not meeting the specific requirements for an evidence-informed ethical and legal practice according to state jurisdictional practice and data security and informed consent in the law, meaning you're probably not practicing according to your license either, if you see where I'm going with this. So while they are aspirational in nature, by definition they are, in many of our minds, they're really not that aspirational, because if you don't do it, you could get in trouble by the APA, if you remember, of course, and you can get in trouble by the licensing boards. And then, we're talking right now with a trust organization, malpractice coverage. We don't want any of this. So the general statement is that we want to do our due diligence to be able to implement these, even though they may be considered aspirational in nature. So that's the end of my soapbox. I hope it made sense. So these are the guidelines. So the red are the new ones. So we consolidated, renamed some things, and added 4 new guidelines. We went from 8 to 11. Yeah, anyway. Okay. So anyway, we consolidated some, deleted some. That's why it's 11. Sorry. Just had a stroke there for a second. Anyway, we have competence of the psychologist. We have informed consent, data security, management, and transmission. This was one of the ones that was consolidated because it was kind of split up into different things. We brought it all together so it wasn't spoken about in many different sections. Data disposal, interjurisdictional practice, clinical best practices in testing and assessment. Those were essentially already present to a degree in the 2013 guidelines. What we did is we then added 4 new guidelines that either expanded upon things that were already there. In other words, documentation and emergencies were already touched upon. They just didn't go into a whole lot of detail. They were kind of discussed in passing. And When we look at the guiding literature and the field experts and our think tank, so to speak, we said, no, like there are so many unique things to this that people are getting into trouble for. We want to make sure we give guidance. So we have documentation, emergencies, supervision and training, and then emerging technologies. Supervision and training was also another area we thought was a little bit underdeveloped. Not that it wasn't discussed at all, but there's a lot of people who are teaching and training or conducting research, and we want to make sure we are covering the broad spectrum and not only exclusively focusing on just the clinical realm. This is how we conceptualize the document when we look at the guidelines. We started with the competence of the psychologist. That was more an umbrella. So as you're going to see in a second, when we break these down, they're broad. They basically outline everything that are then explained in the next 10 guidelines. So the competence relate back to those competencies that we talked about. And those competence is broken up into ethical, legal, administrative, clinical, and then education, training, and supervision consideration areas. So we have our informed consent, our data security management transmission, data disposal, documentation, interjurisdictional practice. We then have our clinical with our best practices, testing and assessment emergencies. And finally, we have our training and what to do with emerging technologies, including in the training aspects and in the training components. So I hope that kind of made sense. If you read the document, also, this is how it's organized and it's explained in that. But think of one as an umbrella for everything else, essentially. And what's discussed in one, there's more detail in the rest of them. As I mentioned when we first started, I created a little very quick crosswalk for everybody. It is not anything too special. If I really broke it down, it would have been like a 50-page document. So all I did was I took the general statements and compared them across the 2013 versus the 2024 guidelines. And you'll see that some was kind of a one-to-one. We changed the verbiage. Some, like the second one there, you can see there were multiple standards that kind of said the same thing, so we collapsed them. And then if you look at the document, you're going to see just some blank areas for 2013, and we have a 2024 one, or vice versa. So I hope that's a little bit helpful just to visualize where the changes occurred. Now, we're going to go through one by one, and as promised, we're going to break down these guidelines. The way I structured this, just from an ease of digestion, because I know it's a little bit dense and there's a lot that we're going to be talking about, I wanted to highlight what the APA guidelines say specifically. So I'm going to give you a general statement, literally word for word from the guide. And it's just like a sentence, so it's not that bad. We're going to talk about a summarized rationale. So I'm not going to type out the multiple pages of rationale, but I do want to give you some bullet points in terms of what the rationale was for inclusion of this guideline, as well as what the guide says in terms of application of this statement, including the rationale. So how does the APA guidelines suggest that you as a practitioner implement this guideline to ensure an ethical, evidence-informed, and safe and legal practice? And this is where we go off script a little bit. This is where I told you I'm going to give a little bit more of my opinion, because I want to talk about how you as an individual provider can actually take this information and apply it in real life. So if you were to leave here and say, okay, I'm all motivated. That was a fantastic presentation. I stayed awake and everything, and I want to make sure that I can apply it. I want to give you just a little bit extra. Like I said, we can't go into the minutiae of everything just for the sake of time, but I do want to give you some guidance on that. So I hope that's at least somewhat helpful. And again, you can augment that with what's in the resource guide, as well as the resources I'm going to be giving you as we go through these. So let's start, with the competence of the psychologist. This literally piggybacks of everything we've been talking about up until this point, in that telepsychology is a series of competencies, and therefore psychologists take reasonable steps to ensure awareness of evolving competencies that are relevant to their practice and the patient, client, service recipient outcome, as indicated by up-to-date research and other relevant literature. And you can see there, just in the verbiage, we're trying to ensure this is not just a clinical matter. It could be the patient, it could be a client, it could be a service recipient if we're talking about research, or we're talking about a consultation, or what have you. So telehealth or telepsychology is a series of competencies, and you not only have to know right now What is the research saying so that I am competent in the competences of the competencies, or I have competency in the numerous competencies, but I have awareness of where to go and what to do to maintain those competencies into the future as things continue to evolve. So this generally says that know what you're doing right now and also know where you're going and how to find that information to make sure you stay up to date. Excuse me. So when it comes to the rationale, psychologists should provide professional services only within the boundaries of their competencies. Makes sense. That literally goes along with the 2013 guidelines, as well as the ethical code, as well as everyone who's licensed. Every license has a statement about this of only practice within the boundaries of your competence. This is based on numerous factors, and we tried not to narrow it down just to one. So this is education, training, supervised experience, consultation, and CE. They should sound very familiar because it's the same thing for non-telehealth, for non-telepsychology, for non-telemedicine. Graduate education. That's what you learn in your classes. Now, this is a little bit limited, just to be honest. So a bunch of us did research, and myself, Fry, Gardner, Salmons, and other people, what we found is pretty much the same thing on how graduate education is, let's say, developing. We're not quite where we need to be. And there's a lot of need in terms of education in graduate education before people really get to that training to make sure we have a didactic foundation. So we're getting better, but we're not quite there. That's why we need training. This is practicum, essentially, hands-on training. Supervised experience goes without saying. This also means that the supervisors have to know what they're talking about to be able to supervise, hence a different guideline. Consultation with like-minded people. So if you are not a student and you did not have that education, because quite frankly, I really didn't either. You know, going back a couple decades, I didn't have a whole lot either. We didn't talk about telehealth. We didn't really train in it. It didn't really exist as much. So a lot of it was education, supervised experience, consultation with field experts or people who know better than I do. That includes psychologists, physicians, as well as legal. I've called the trust before. I've called, other organizations, licensing boards across the country and world to get clarification on their laws because very confusing, right? And I'm not a lawyer. So, and then CE. Obviously, you're all sitting here. I'm sure at least one or two people are getting that SciPact certification to 3 hours, but CEs are very important. And, not all CEs are created equally. So hopefully you take a variety of them to get different opinions. Because what I say is my understanding of the literature, plus my opinion, plus the research, but doesn't mean you won't learn something else from somebody else, right? So we want to make sure we cover the bases. Now, when it comes to application of this one is the easiest. We just recognize that telepsychology competencies really do differ from in-person or what they call, quote unquote, traditional practices. There are, in fact, many, many differences in terms of how you do things. What about security and confidentiality? What about room setup? A lot of factors that just weren't relevant when we originally started. So, and it can vary further by the text selected, as we've mentioned numerous times. I know I sound like a broken record. That's on purpose. I want to make sure I'm hammering a couple points home. Now, very, very important. This is where we get into some trouble. When we talk about the education, doesn't matter where it came from, all the things I listed before, we have two components that are essential, not just for telepsychology, but in training in general, hence why we have accreditation standards. We need both didactic education to learn the basics, to be able to understand it, and then applied experiential activities. It is not enough just to read a book. Like how many of us have read a book on CBT or analytic or dynamic or TLDP or, PCIT or whatever. And then you go into a room and none of it works. And none of the things in the book actually apply because something else happened or very little apply. How about that? In other words, we need that basics. We need the theory. We need the understanding. We need to understand how to modify the treatment while maintaining the fidelity of the assessment or the treatment or the practice. But we also need applied hands-on activities. That's where the supervised experience comes in. And when it comes to what we should be learning about and having these experiences is based on content, technical, and population-specific competencies. And we're going to break these down. But just to put in perspective, like you can read a book on how to build a car. Doesn't mean you can then go do every step of the way, because what if there's a part that's slightly different than what's in the manual? You need extra understanding beyond what you're reading. So when it comes to the content areas, this is more of the researchy part compared to the technical and the population specific. This is where we have to take a deeper dive into what the literature says. So this is the research on both the efficacy and the effectiveness of the mental health challenges and the technology. Efficacy, just to make sure we're on the same page, efficacy and effectiveness are often used interchangeably. They are different and they do mean different things. In a super, super simplified version, so nobody yell at me, please, especially those researchers, efficacy is under controlled settings. So randomized control trials, essentially. So it's under controlled settings where we can control variables to be able to assess specific factors, and it's in lab conditions, essentially. Effectiveness is non-controlled real world settings. So this is the non-controlled thing where it's a little bit harder to figure out certain factors, but the same token, it's more real life. Now, we want both. We want those controlled studies because you want to be able to assess which factors are contributing to the positive outcome. But there are critics of efficacy because they say that's not real life. Like in clinic, I cannot control all these things, so that research isn't super helpful. I don't know about that. It does have importance, but the effectiveness data, yes, it will vary study to study. And that's why if you look at it across research, you kind of look at the mean of what is the general takeaway. Well, all these studies on effectiveness, while the numbers varied, all but one found positive outcome in terms of these variables. So if we have enough, the individual differences start to wash out a little bit. And again, oversimplification, I know that, but I do want to at least make mention of that. Okay. Now, in addition to that research, we have to know about the difference between in-person and telepsychology encounters. And while some people might be going, duh, no kidding, the reality is that when you look at the research studies, the vast majority of people cannot give you specific details between in-person and telepsychology. They know there are differences, but beyond confidentiality and the fact that using video or telephone or the technology, people can't really go into detail of what about the latency or the lag or the video or the audio? What about confidentiality? What about data security? What does the law say? What about cross-state, cross-province, cross-territory, cross-country practice? How do these things differ? What about problem solving? So we have to know these individual factors as well as how to adapt whatever we're going to do to make sure it's effective for that individual and doing it in an optimal way. We don't want to provide subpar care, right? We want to make sure that we are adapting things in line with what we do. And if it doesn't exist, how can we draw a parallel to be able to validate my practice? And there's just my bias, you can take it or leave it, is I always try to do things as if I'm cross-examined. So can I reasonably justify what I did and why I did it if I'm ever questioned? That's kind of how I practice. So if I'm going to adapt a practice or an assessment and I'm called into court to justify why I did that, can I reasonably justify? If the answer is no, then I kind of have a little bit of a discussion to be had with myself or consult with somebody because I want to make sure I'm doing not just what's best for the patient. That's very important, but also I want to protect myself because if I go down, that's what, 40, 50 or more people a week that I cannot help. And that's a problem. So I have to kind of look at the big picture. Ethical, legal factors, we've talked a lot about those. Safety planning. This is one that we just talked about, that it has its own dedicated emergency guideline now. Practice logistics, including documentation. This was also broken down to its own thing. Conducting research is a content area. Advocacy is a content area. If you're going to be doing research, you also have to know about what about data security? What about cross-state or cross-jurisdiction data collection? What about safety planning if you're assessing depression or suicidality? Now, one could argue this is all the same as it was in person, but if you're using video interviews or you're doing video treatments and collecting it as part of research, well, then we start getting into some different territory. On the technical side of things, what about the technical components for the practice? What did you pick? Why did you pick it? Why didn't you pick something else? Is it cost effective? Do you know how to fix it? What about the data security and troubleshooting? And not just fixing it, do you know how to communicate troubleshooting to other people? Are you able to communicate this stuff? And I laugh because we just had a student the other day who was calling on the phone, and they kept losing their words, and they were talking to an older adult who just had no idea, and they had skipped 3 steps. And I kid you not, the person was still trying to find the on button to the computer because they were working on their friend's laptop or their child's laptop. So the student was going on and on and on about click here and do this, and they were being very respectful. And I'm sir, can I just jump in for a second? And it turns out we needed to take like 5 steps back just to make sure. And then they got it up and running, so it worked out well. But we need to just make sure we're not jumping the gun and assuming things. And finally, population-specific competencies. So research-informed guidance on whom is likely to benefit from different telepsychology modalities. Or if you want to flip this, which technology is most applicable and helpful for which demographics and which symptom presentations, as well as how to evaluate those appropriateness for different factors, which is a whole body of literature unto itself on what you're assessing. And I will give you some resources in a little bit when we get to that guideline. Consider individual organizational structures. I can tell you where I work, I have to use Zoom for healthcare. Can't just be willy-nilly going through and picking those that I like. When I was in private practice for a few years, in between some other things. I've always worked at hospitals. I had a couple of years where tried out academia, wasn't for me, so came back to the hospital, but I was in private practice, and I can use whatever I want. And, a lot of the programs were free, but you get what you pay for. And I wound up paying for some to make sure that I was getting what I needed to. But again, if your organization requires certain things, you just want to make sure you're covering your behind, because ultimately, even though the organization requires it, you still have to follow. It's still your license. You still have to make sure you're doing well with it. And finally, adaptations for special populations. This one probably goes without saying, but military, individual disabilities, kids, older adults, there are differences, of course. So how does this relate to real life? Well, real life application means you do the same thing you would do for in-person practices. You review the literature, you seek training and consult, you seek supervision, and you want to foster education among graduate programming. We hope to be training people at earlier and earlier ages because we know that exposure to technology and telehealth on the graduate level and early not only fosters a comfort, but future use of it, or at very least, people say, I don't want to use it now, but they have the foundation to build on later. So I've worked with a lot of students. I created a telehealth course for graduate students and published it. And I had students who say, I loved it. It was great. I don't know if I'm going to use it right now. And I work with other students who say, I hate this. I don't want to use it. Okay, fine. But years later, they popped at me, I want to use it, or I can make more money using it, or I'm forced to use it. And having that foundation, yes, I had to update myself. Yes, I had to look at research, but I had a foundation to build from, and I had a comfort with it already that I wouldn't have had otherwise. That's extremely powerful. So this is kind of how I look at the research. So if I was to go to the research, I would want to break it down like this. And again, you don't have to get this granular, but this is kind of my thought process. So if you're looking at research on trying to figure out what works for what, I always start by just either looking up or just confirming the efficacy and effectiveness of the specific assessment, intervention, or you can substitute research practice or advocacy practice or what have you. I figured I was talking to a clinical population, so I'm tailoring to that. In general, in other words, does this work in general? And while that may sound kind of like a simplistic statement, I'm a board evaluator for ABIP, and I can tell you, I see all kinds of stuff that isn't necessarily evidence-based practice. People were just told to do it as part of their education. They took it as gospel because a supervisor said so. And not everything is equally as empirically sound. So just in general, is there efficacy and effectiveness of this specific technique? And then second, is there efficacy and effectiveness research or literature for that for the specific population in question. I'm using that broadly. That could be race, ethnicity, age, what have you. Okay, we know it works in general. What about the specific technology I'm selecting? And what about the technology for that specific population? Same thing. So you just repeat again. We have general, now we have our tech, and then we integrate the two. Important adaptations that must be made if you're going to be using the technologies in general. So I'm using video for therapy and for specific populations, and then how to troubleshoot the technology and the processes. So again, starting very broad and getting more narrow, that's how I look at the literature, at least broadly. And given rapid changes, as our twins from The Shining tell us, learn telehealth was forever and ever. This is not something you're going to ever kind of stop, just like with any other healthcare specialty. We just have to keep learning over time and just keep it going. So now that we have our broad one out of the way, let's break it down a little bit into the actual guidelines that one alluded to. We're going to start with informed consent. So our blanket statement: psychologists strive to obtain and document informed consent, recognizing the distinctive considerations associated with the provision of telepsychology services. Okay, now what does this mean? Informed consent plays a critical role in establishing the foundation of the relationship between psychologists and their patients, clients, or service recipients, particularly in the context of telepsychology services. And psychologists strive to deliver a comprehensive and transparent description of their telepsychology services that includes a review of the unique benefits and potential risks of the modality, as well as policies and procedures relevant to use. So that is a lot packed into 2 sentences. So what this means in English is that we want to obtain and consent not just the psychological services, but also the specific use of telepsychology. This is a dual consenting procedure. When COVID first came up, there was a lot of people who, and again, not meant to be rude, I'm saying when you look at the research, there's a lot of people who just added the word telehealth to their informed consent document and said, we're good. Not true. Even going back to the 2013 guidelines, as well as documentation by different organizations, including the Trust, it was discussed that we need to have telepsychology specific information either built into the informed consent or even as a secondary informed consent, like a supplement or an additional on top of the general, should you provide telepsychology services. So many of you are probably going, yeah, I already knew that. But again, when you look at some of the information and you talk to people, some people updated their informed consent, but not everybody did. They kept saying, I'll get to it later, I'll get to it later. So with the 2024 guidelines, we are strongly encouraging you, again, aspirational, right? We are strongly encouraging you that if you're in a hospital or something like that is taken care of, okay. But if you're in practice for yourself or your organization, or you're in the position to be able to help update this, we really want to make sure that the informed consent is going into the detail necessary to provide people with enough information to make an educated decision about whether they want to do it or not, as well as the stipulations of continued telepsychology, as sometimes people want it, but it may not be in their best interest. So what about real-world application? As I mentioned, all organizations have stressed informed consent. This is not unique to telepsychology. All organizations always stress informed consent. That includes whether you're doing assessment, intervention, research, so on and so forth. What they recommend is getting it in writing, or writing it down and signing it, of course, but also going over it verbally. Now, maybe not going over every possible aspect of it, but making sure we go over the high points, because let's call it what it is. You know, anytime you get an end user agreement from a new app you download or something, do you go through the 45 pages of documents and read every single word? Probably should, but you know, there's been episodes on The Simpsons and South Park and all that, and all what you agree to. But the point is that you want to go over the high points for people who either maybe don't read as well, don't want to read, or maybe have some disabilities, maybe don't quite understand it. Meaning, we want to make it understandable to all individuals. And while there's no real universal to this, like the government does not say you have to do this, most guidelines suggest adhering to research standards, meaning about 8th grade reading level or below. Now, there are people who are suggesting fifth grade reading level below, but the idea is to make it understandable. You don't need jargon, you don't need the legalese, you just need people to understand it in a way to justify your practices. And if anyone's in doubt, Microsoft Word, I mean, there's other ways. Microsoft Word has ways to tell what reading level or what grade level it is. If you turn on the feature, you can always Google how to do that if you're not sure. But it does give you an estimated reading level. And I can tell you, I don't know about you guys, I have a real problem getting to that fifth grade, eighth grade reading level sometimes. I don't know what words I'm using, but sometimes it's very difficult. So I have to put thought into what I'm writing to make sure it is readily understandable to people besides me. And very, very, very important. A lot of people misinterpret or have biases in certain ways. So it's very important that you invite questions. Now, I'm not saying you spend 45 minutes on this. A couple minutes is usually enough. But a lot of times, I can tell you personally, from personal experience, is that a lot of people have these thoughts about what they're doing, but it's not really what we're going to be doing in real life. I mean, there's still factors of if, we still have people who come in and say therapy is going to be, where's your couch? You're just going to be staring at the back of my head like on TV, right? So not quite. I'm more behavioral, but not quite. And then once I explain, they go, oh, okay, that makes sense. Same thing for telehealth. Some people literally think they're going to be having video from wherever they want and doing whatever they want. Or some people think it's just going to be therapy where they just talk for an hour while the psychologist sits there and nods via video. So it's really important to make sure we're giving information up front, including what their responsibilities are. So with that said, in real world application, what am I talking about for the informed consent document? Well, when you look at the research and when you boil it down, not just the research, but the consolidation of available informed consent documentation, including information from the APAs and the trust and different organizations, when we boiled down what factors were included, we found that there were really 6 kind of components that were included across almost every informed consent example and document. We found those to be the indications of standard practice, strengths and limitations, general delivery factors, communications, troubleshooting, and administrative. And let me just say up front, I'm going to go through these very quick. I'm just going to give you a couple points. So this way, if you're interested, you kind of know what you're looking for. Not all are going to apply to everyone, and you may not need all of these. It just depends on what your unique practice is, or you may need more of these. While I'm going to be giving you recommendations, again, I am not a lawyer. I'm not giving you legal advice. So if you are going to be updating informed consent, I do suggest just consulting with legal counsel to make sure that there's no issues with the verbiage you're using or the phrasing you're using. So these are the factors. We would always start with the indications of standard practice. This includes the types of services in telehealth you do and don't provide. So for example, me personally, I do video, we can't do telephone, and I don't do text. I do messaging program through the electronic health record. That's what we have to do. So I'm not emailing you personally under most circumstances. And if I do, I have to use an encrypted server. But basically, I will do video. I'm not doing video assessments for neuropsych, or I'm not doing video assessments for this. So we will do therapy. Video is an option. Telephone is not. So I say up front, also, I personally don't provide group therapies right now. I used to, but I don't right now. So I do or do not provide these things. And unique to telehealth, this is the tech I use. And if you agree to using video, you must use these platforms that I approve or the hospital approves. It's not what you pick. And licensure and jurisdictional limitations. I can only practice in those states or jurisdictions I am licensed and approved to practice. Therefore, if you travel a lot, if you are a cruise employee or a truck driver, or if you are on vacation with your children, you agree to tell me up front where you are. I always ask anyway. It's good practice just to ask them, but you understand that I can lose my license and get into trouble if you are in a specific place and I am not approved to do that. But sometimes if you give me enough notice, I might be able to get approval, especially if you're going to be there for a while. So there, again, when there's a will, there's a way, but you have to understand my practice is limited. When it comes to strengths and limitations, indication that telehealth is an emerging scientific literature. There are limitations. And as I said earlier, there's enough consistent evidence to suggest good stuff, but we don't know everything. Now, a critic of this statement could say the same thing for anything, CBT included. We don't know everything. but we do know there's enough there to say it's good. And the benefits and risks. Well, we already talked a little about this, but the benefits, I can reach you where you're at. We can do video. It can save you time and money potentially. But system could, go offline. Someone could listen in. We could have a data breach. We could have all those issues. So we have to discuss those up front. General delivery factors. Describe how the electronic service differs from in person. We've already talked about that. What are the minimum tech requirements? We talked about that a little bit, how not everyone has reasonable technology. Now, it is true that the majority of people do. And all I usually say is, if you have a phone or a tablet from the last, 5, 6, 7 years, probably works. But if we're talking you haven't updated your technology in 20 years, we should probably test it before we go full force just to make sure. You want to ensure they have a private environment. Again, this one goes without saying, but I cannot tell you how often this is a problem. And for those of you who are actively practicing, I'm sure everyone in this session probably has a story about how people were trying to connect while they were driving or from a store. Some of my favorites are a colleague of mine was telling me that they had nose shot and they just saw clouds whizzing by. They couldn't figure out. Well, it turns out that someone was riding their bike with a phone mount on the highway, the shoulder of the highway during rush hour and trying to have a session. Maybe not as good. Okay. We want to include a clause of alternatives if telehealth is deemed inappropriate. This is super important, at least to me. I determine whether telehealth is useful or we're going to keep doing it. I do believe it is important to have the patients involved in the discussion, but they shouldn't be the sole deciding factor. And I can tell you here, we've had internal discussions about people go, I want video. Well, we tried it. It didn't work. We're billing you for nothing, or we can't bill you. Or you're not getting better and we're spending 2/3 of the session just trying to fix tech issues. So while your desire will definitely be taken in, I will do everything I can to work with you. Ultimately, you as the provider are making the evidence-informed decision on whether to continue or to offer telehealth services or not. Communication. I love this one because it gets people into trouble. Detail the average turnaround time. I do not want to be inundated with 1,000 messages. Give me at least 24 hours to respond. Usually I'm pretty good about responding within an hour or two, but give me at least a day. And if not, then it's okay to follow up. But do not message me every 15 minutes. Discuss the appropriate, inappropriate types. Do not text me or email me that you're going to kill yourself. Now, obviously, we can't stop people from doing that, but I do tell people I will not be available. I will not be checking between these hours. So you have to understand that. And if it's an emergency, please go to the hospital. Please tell me afterwards. I'm happy to get you in, but I'm not going to be looking at the message at 2:30 a.m. And if you are someone who's going to be using messages or texts or something like that, put an indication that they may be delayed or not received at all. And that is not an indication of whether I like you or not, or I'm ignoring you or not. I may literally have not seen it. So we need people to understand that and to follow up if they don't hear back, say within the 24 hours. And set clear boundaries. I will only work between these hours. I will not see you on weekends. I will not see you at 2 a.m. I will not see you when I'm sick. Make sure you're dressed. I have seen people come out in towels. Not appropriate. Again, the less seriously you take this, the less positive outcomes there are because you just don't put the effort in. You want to have a plan B. What do we do if telehealth fails? Well, we try this video backup. We have a plan B. What if we're like 45 minutes into a 50-minute session? Well, if we're X amount of minutes in, it doesn't work. We just reschedule. I can call you or we can email, or electronic health record. We can just reschedule. And finally, I mentioned this earlier, the billing arrangements. If you want additional examples, and I mentioned I pull from different places, here are some really good examples from the Trust APA and then some Canadian resources. I actually find a lot of the Canadian resources quite good and have a lot of good detail. And again, what I just showed you is a consolidation of all these, but hopefully it can give you a starting place to either build or update what we already have, or just check what you have. And if you want specific language to choose from, and you're just not sure how to deal with it or how to write it up, in addition to consulting, of course, the HHS has a nice resource for practitioners on HIPAA compliant language when you're using remote communication tech. Here's the link to it. It'll be in your handout. It has a lot of really good information, and you can see on the left, it breaks it down by different topics. It can be really useful for a lot of these guidelines as you're kind of drafting that informed consent document, or if you just want more information about general use. So that brings us to data security. I apologize. My throat's very dry. I'm just getting off antibiotics. So my throat goes. I apologize. So when it comes to data security, psychologists who provide telepsychology services seek to take reasonable steps to ensure security measures are in place to protect patient, client, service recipient data from unintended access, disclosure, loss, or corruption. Again, in today's day and age in 2025, most people know we need to have appropriate security. The problem comes into what is that appropriate security, because the use of telecommunication presents unique threats that really, some of which, but not all of which, are possible in person, but a lot of them are unique to telehealth. So computer malware being an umbrella term that could include viruses, spyware, ransomware. We can get all kinds of junk on our computers. And let me just say up front, there's always one person. Yes, Macs get them too. What Macs were and what Macs are two different things. They are susceptible to malware and all kinds of things as well. Even though sometimes it's harder because of the coding, or at least it used to be, I guess. But yes, it can get that, as can your phone, as can your tablet. Anything that's essentially a computer is in fact susceptible to these things. Hackers. I don't mean the hacks that you see online. I'm talking about true hacking of breaking data security to get where you need to. If your security is not very good or very minimal, remember, there's a lot of AI out there now that can crack things, so you want to be careful. Loss or theft of technology. People always say, I've never lost anything. Not until you have, right? And I remember when I was an intern, I had a supervisor lose a laptop, and I saw it was a good learning experience for me because I got to see what the process was to report and do all this stuff. But it was an accident, like very good supervisor, awesome trainer, awesome psychologist, but just things happen sometimes. But it doesn't have to be just the tech. It doesn't have to be data security. It could be loss of the technology that we have to plan for, damage to the hard drives or the portable drives, or corrupted software. I'm from Florida originally. We had hurricanes. We had floods where computers and hard drives and servers were completely destroyed because they went under. And some places had backup off-site, which is obviously suggested, or none, and they lost a lot of stuff. And that creates a whole wealth of issues well beyond the tech itself. Ease of access to the unsecured files. We need to make sure the data security is good, as well as making sure all the tech is functioning properly. And this includes not just you, but if you're using any third-party companies, we have to make sure that we are doing our due diligence to ensure that those third-party companies, say Zoom or Google or what have you, are doing what they need to be doing. Because sometimes, I'm sure all of us remember to some degree the Zoom bombing, how Zoom said they had data security, and then it turned out maybe not as well as they said. And having the agreements in place help protect some level of liabilities. In addition to just the tech threats, we got to have awareness of the data creation, storage, and how it's transmitted, and the relevant laws for how we manage this data. So let's put this in English for a second. That means you got to know the data security laws and the data security management regulations, I guess I should say. In the USA, it is HIPAA. I'm not going to go into super detail about this one. I'm assuming we're all familiar with HIPAA. But what I will say is this is going to vary by country and province and territory. So, for example, in the European Union, the General Data Protection Regulation is their version of HIPAA, so to speak, their data regulation requirements. Not every country is in the European Union, and some have left. So, for example, England they left and they changed the regulation a little bit. PIPEDA for Personal Information Protection and Electronic Document Act in Canada. If you think those were complicated. My colleagues and I recently wrote a paper for Canadian regulations for telehealth, and it gets very complicated because while you have your countrywide regulation, in Canada, individual provinces and territories can actually change it and make their own data regulation if deemed equivalent or similar enough to PIPEDA. Meaning, just following the countrywide regulation may not be approved in that specific province or territory. You might have to do extra that's unique to them. So think of it as in like if the United States, every state could do their own kind of version of it. So that's really why you have to put this in perspective and realize that even if you're following HIPAA, if you're following HIPAA, there's no guarantee you're following GDPR because under most circumstances, GDPR is more rigid. So if you're one to practice overseas, you got to be careful because I don't know about you, but I wouldn't want to be held liable in two different countries for something that happens. Real world application of this. HIPAA, we have our physical safeguards. That means we have locked doors, biometric scanners, we have the computers put away, the servers put away, literally physically restricting access. We have our administrative safeguards, literally personnel training. We all have, well, most of us have the HIPAA training, and we have cybersecurity, and we have data managers to make sure only those people who should have access do have access. And then we have our technical safeguards. This is the cybersecurity stuff. We also have to know data breach requirements. And I mentioned earlier those agreements, they're called business associate agreements. In English, this means that either you as a provider or your organization signs an executed agreement with a third-party company that they agree any data that's transmitted or protected health information that's transmitted to them or given to them, they agree to uphold the standards of HIPAA or whatever the contract says. And if there's an issue, you have less of a liability because they promised to do so. So with all this said, how do you do this? Well, unfortunately, there are no universal technical guidelines for how to do all this, but there are joint papers. These are the ones that almost every guiding organization and the US government suggests to use. So the NIST and NICO standards, so the National Institute of Standards and Technology and the National Cybersecurity Center of Excellence. There are dozens of papers. Many of them are in your resource guide. Don't have time to go through all of them, but it does go through the details of what about passwords? What about encryption? Meaning we need at least 128-bit encryption or higher is what the current standards are. In English, encryption is taking the data, and when it's transmitted from one end to the other, you want end-to-end encryption on both ends. It makes it a garbled mess. It's unintelligible until you decrypt it with a decryption key, and then you can read it again. So think about like taking a Microsoft Word document, making it wingdings to someone who's never heard of wingdings, and then you put it back into Times New Roman afterwards. Kind of a simplified example, but that's the idea. They also talk about data breaches and whatnot. And again, we don't have time to go into all the details, but I would encourage you to take a look at it. And one of the better guidelines that guidebooks I really like came out last year, Implementing HIPAA Security Rule, a cybersecurity resource guide. This is a nice resource guide that you can use as a checklist that literally breaks down all the major factors that you need to consider. And if you can't go through this and say yes and answer the questions reasonably, it'll give you an avenue to, I need to look into this, or I need to learn about this, or I need to fix this to make sure that I'm practicing according to this regulation. And if this looks boring to you, the other guiding organization has a nice little, it's a joint endeavor where it's kind of a choose your adventure point and click. And it's a website that guides you through a lot of the same information, a little bit more of an aesthetically pleasing kind of method. I would encourage you to go through both. They're both very good. What about data disposal? So once we have the data, what do we do with it? Well, according to the guidebook, psychologists who provide telepsychology services are encouraged to take reasonable efforts to dispose of the personally identifiable information, to the PAI, which is an umbrella term that includes protected health information, the PHI, and related texts used to create, store, and transmit these data in an appropriate manner. Now, this is important because even a smartphone, if you're opening things on your phone, it stores some data. So just deleting it doesn't necessarily do anything. It can still be recovered. So this means you want to have policies and procedures for the destruction of both paper-based and electronic information. And you also want to have processes for physically disposing of the technologies to create, store, and transmit the information. So it's not enough to just delete the data. if you're going to be getting rid of the computer or selling the computer or trashing it, you want to make sure that you are doing what you need to. And you conduct an analysis of the potential risks, and you have a risk and you have a plan of what to do for all the data that you need to destroy. I know what I'm transmitting. I know what I have. I know where it's stored. I know how to get rid of it. So if you are still wondering what I'm talking about, we're talking about sanitization. We're talking about taking the information or the technology and basically physically or digitally destroying it so that the media cannot be recovered and accessed by people who shouldn't have access. So the target data that people would want is infeasible. We cannot get it. And one of the better papers that goes into detail, again, is by NIST, Guidelines for Media Sanitization. And they outline 3 processes. And these are all in the guidebook. So they talk about clearing, purging, and destroying. In a super simplified way, clearing means you sanitize so that all user addressable storage locations against the non-invasive data recovery techniques. In other words, someone can't just go to your recycling bin, click undo. So it's rewriting over the data. You can't just delete, it's still recoverable, and or restoring device to factory settings. Now, this is not the safest because there are still ways to undo this. And sometimes, depending on how you factory reset, sometimes there are things that are still stored. So if you're not sure, just make sure you consult with somebody or you consult with a third-party company. So like, for example, our hospital has contracts to dispose of things in a safe, reasonable way. So clearing is probably the least secure, but it is one of the ways. Purging is physical or logistical techniques that render the target data infeasible using state-of-the-art lab techniques, where some of the more popular ones are degaussing, which is essentially demagnetizing. You literally demagnetize the technology so that it will not work properly anymore, and you basically screw everything up. That's essentially what it is. And then my favorite is physically destroying, like literally destroying. You can shred it. And yes, there are shredders for hard things. They're big gears, basically, that crunch it up, or literally shred it with heat and blades, or disintegration. And you can probably guess what that is. So there are ways of physically destroying. Now, like I said, if you are going to be using a third party, you want to have a BAA because you are giving them all of your data and the tech potentially. You want to make sure that they agree to follow all standards put in place by these organizations, by HIPAA, and whatever requirements you have in place of what they might have to give back afterwards, or they agree to dispose it. And while this sounds very simplistic, there have been, you can Google, there have been companies that say they're going to destroy it, but what they did instead is they cleared it out and then try to resell it online to make a side profit, like a side hustle. Not great. Well, not great for a lot of reasons legally, but not great for your standpoint, because if we didn't have the BAA in place, we have less protection over that. You know, the wink, wink handshake only takes you so far. And one of the things that we talk about in the guidelines that's important is this is not just on the practitioner, on you. This is also on the patients. We want to educate them that if you use a phone or a computer at the library, I can't guarantee that there won't be data stored on there, not even cookies. There might be other things on there that have your login, have your information. Things are tied. Like, if you are good at technology, when there's a will, there's a way. So we just have to educate others on what is appropriate, how we use them, how we don't use them, and what we have to do to make sure the data is disposed of properly. And if you're working with somebody who, say, has to borrow a computer or a tablet or a phone, they just have to be aware, part of that informed consent process, of what are the limitations of this. Documentation. So we're almost about halfway there. And they get a little bit quicker as we go. That makes you feel better. Documentation. Psychologists seek to diligently create and maintain clinical records that identify and incorporate the specific administrative and clinical elements of telepsych services delivery that are in accordance with relevant laws and ethical standards. Okay. So literally, you document in line with ethical and legal. We also threw in there insurance too, by the way. So it's not just ethical and legal, it's we want to make sure people are also paid. While that might not be the point of the document, there are factors that we talk about that a lot of insurances want to see. So if you include everything, you should kind of be covered. And again, can't guarantee anything, but that's the thought process. What this means is that psychologists take reasonable steps to adhere to the same legal, ethical, and professional standards that they do when completing in-person services. Same thing. If you don't document, it didn't happen, so to speak. So document, document, document. Again, CYA, cover your behind. Here's the issue. Documentation of telepsychology is inherently more complex than what you would talk about in person. There's a lot more factors that we need to document, not just from an insurance and a billing standpoint, but also from a cover your behind standpoint, because if something happens, or if you decide telehealth is no longer appropriate, you want to have rationale for doing that, especially if someone pushes back, let's say, or becomes litigious. You want to make sure you have that documentation. Now, this means documenting both the administrative and the clinical considerations as they apply to the application of the technology. So both are equally as important. So when it comes to real world application, this is not exhaustive, by the way. I didn't want to have a 5-page slide, but the technology unique considerations really fall under those administrative and the clinical factors. So when it comes to administrative, you want to have, again, this is your call. Obviously, you can get legal consultation, but what is recommended is that you have an indication of the location of the provider where you are and the patient is at the time of the service. Now, you can have state specific. We were both in West Virginia. We personally have the addresses listed, so we get specific. That includes the address as well as the state as part of that. We also include either at home or at their job or at a store. We're in a rural area. Sometimes people have to drive to the nearest church or the nearest school just to get Wi-Fi sometimes. So we have to document that we explain the limitations of this approach, and the family agreed to the potential limitations of using a public network. Sometimes we encourage the use of a VPN or virtual private network so we can mask it a little bit. But if you have no idea what I'm talking about, that's fine. We can talk about it later. But the idea is you want to have the location. This is not just important from a documentation standpoint, but also from a jurisdictional standpoint of making sure you're practicing where you're supposed to be practicing, and also from a billing standpoint of you want to make sure you're billing where you're allowed to get paid, so to speak. The tech utilized and the modality. Some people get into detail. I don't really get into detail. Just basically, I use video. We met via video. I don't go into detail of, Zoom for healthcare versus this. I suppose you could. But in other words, I want to say that I am using an approved telehealth method or telepsychology method for my jurisdiction. And I want to document which one I'm using in case there's an issue with it in the future, or it goes well and I want to have documentation of what I did. And that will also justify some of the clinical work of how did I adapt it for that specific modality. Patient authentication. If you already know them, this is not as big of a deal. But if you're meeting people for the first time, having a new visit or doing an assessment, I want some authentication method. I tell people before we start, I want to see an ID, a passport. I want you to hold something up. Of course, you can fake it, but I want to see something. And I can tell you, I've caught people in lies before. I have had parents and step-parents try to pretend to be the other parent to tell me things during a custody battle so the other one gets in trouble. We have forensics down the hallway there. They can tell you all kinds of horror stories about how people have attempted to portray other people. Now, this is not exactly foolproof, but a lot of people, if you say we're going to check IDs, sometimes think twice about doing it. So I want some authentication method, and to document, we verified their identity before we started, especially in the case of an assessment. We document our informed consent somewhere in the document. That's easy. Billable start and end time, including reasons for technical fail. So this is important, especially if you bill time codes, say 90832 versus 34 versus 37, which in English, those are time codes of individual face-to-face therapy. You cannot bill if you are not face-to-face with the patient. And depending on how long you see them will dictate which of those 3 codes you do. So let's say 90837, I have to have at least 53 minutes of face-to-face contact with the patient. And I saw them for 55 minutes total. And of that 55, 10 of those minutes, they were offline because we had tech issues. Well, then I can no longer bill 90837 because I did not see them for at least 53 minutes. I also want to document the reasons for these tech issues, how they were addressed. We switched to a different video platform. We just gave up. We rescheduled. What happened? And how long they were disrupted for. Again, going back to the billable start and end time. Any arising ethical legal issues. I want to document if they try to connect while driving, while at I had a lot of good ones lately, but where they connected from inappropriate places. My favorite ever, and it wasn't happened to me, was someone tried to connect from a strip club. Now, granted, you couldn't hear anything, but they had earbuds in allegedly. This was a case I was consulting on, and I don't know what that person was thinking, but it maybe part of why the therapy was part of it anyway. But the point is, I want to document this because, again, if something should come up or I have to terminate services or if I have to recommend in person or recommend something different, I want to have a track record to validate what I'm doing. On the clinical side of things, you don't have to write a book on these things, but just how are services adapted? So if I was doing an assessment, I used two cameras, one that was this, waist and up, and one that looked at the camera. How do we do this? We had a laptop and we had their camera. One was angled at their hand so I can see when they stopped writing. I was doing behavioral techniques, PCIT, and we did video coaching instead of in the room coaching or one-way mirror coaching. So we coached them in real time. Okay. And they used an earbud at home instead of a bug in the ear that we have in session. The environment, again, going back to, were there privacy issues? Were people there who should not be there? What about location issues, or did others call in? So a lot of times we'll have the patient and one of the parents or the caregivers in person, and then, or they're via video on this one, and we also have somebody else from a different location, especially split families, where they're on video, or someone may also call in via phone, but we're doing the primary treatment or the assessment via video. So just to kind of clarify what's going on. Contacts for safety and collateral. Do we have a neighbor, a spouse, what if something goes wrong? What do we do? And what about that crisis information that we'll talk about in a moment? Accommodations. Did we need headphones? Did we need visual aids? Did those visual aids or headphones or screen modifiers, we can change the font size, the contrast. Did that affect the integrity of the assessment or the therapy? Or did it delay treatment? How did lag affect this? How did video, clarity and the volume affect this stuff? So all things to consider for not necessarily documenting in a clinical note. This could be documented in the record, in a report. Doesn't matter where, but you want to have some kind of documentation. And these are the common factors that come up time and time again in the literature. Interjurisdictional practice. This one is probably my favorite because it's so convoluted. And while it certainly sounds very simple, it gets very messy very quickly. So psychologists seek to be well-versed in and comply with all relevant laws, mandates, and regulations when providing telepsychology services to patients, clients, or service recipients across jurisdictional borders. And one thing that I can tell you I was adamant about is that we include both domestic and international, because I don't think that international is discussed nearly enough, despite a lot of people doing it. So this means you need to be aware of what I told you before: the state, province, territory, and country-specific regulations in terms of practice, data security, safety, so on and so forth. Now, before I go any further, I just want to make mention, we're going to be talking about the primary methods of interjurisdictional practice, but there are regulations. So we're going to talk about the United States, DOD, VA, military, that kind of stuff. There are internal kind of self-governed systems to the government that have their own policy. So if you are part of those policies, that's great, but we're going to talk about the other things for people who are not part of these policies. As of 2025, there are two ways to practice across jurisdictional boundaries. One, to be licensed where you are and where the patient is. This is good for a lot of ways, but it also could be costly and take, a lot of time and money, especially if individual states require additional tests or fingerprinting or FBI background checks, so on and so forth. But it does allow you to be able to supervise under your license and do cross-state work a little bit easier. Or you can join an interjurisdictional compact, which for clinical psychology is PsyPact. Now, interjurisdictional compact, I think most people are aware of this by now, but it's a legal agreement that's ratified into law. The idea is that individual states entering this into law and joining the compact can then have the individual providers who are licensed in that state join the compact. That person can then practice in any of the other compact states without having to take additional tests, pay, register, do all that stuff. So it's very helpful. I actually really like SciPac. I do think it has a couple limitations as it relates to training, but overall, it is super, super helpful and honestly way cheaper than getting licensed in, all the states and territories and provinces and all that stuff. In a real world setting, though, this is important because you have to have knowledge of a lot of different factors as it relates to that cross jurisdictional practice. This includes whether you are fully practicing or doing, let's say, 30 non-consecutive days of practice, because a lot of states have temporary practice in person and virtually, but it is not as simple as it was during COVID with all the restrictions being alleviated. Because some states you have to register and wait. Some you have to pay. Some actually have tests, even if it's a temporary practice. So it's not as easy as to tell a patient, yeah, I'll do it next week. It could take you a month or more to get approved. So you need to have some kind of information up front. And just because you can practice across states, whether you're licensed or doing SciPac, you still have to know about data security, mandated reporting laws, which will differ depending on Tarasoff states, age of adulthood, age of consent. This includes legal, sexual, Romeo and Juliet laws, all that fun stuff. Bartering allowances. Some locations allow for more bartering than others. Some allow for none. Some allow for a lot. And then red flag laws, courts taking away guns, which I don't know how often that actually happens in real life, but there are laws and they do differ by jurisdiction. And what SciPact is very clear on is just because you can practice into different locations, that doesn't exempt you from having to know about the laws and regulations of that specific location. And that's true whether you're doing SciPac or not. Even if you're not doing SciPac, because that's United States specific, I'm practicing in Spain or Italy or Australia, I still need to know their regulations. So when it comes to states, if you want up-to-date information and resources, I really like two places. I really like the telehealth resource centers, which has a broad kind of network. And then if you look at the picture, they also have regional. So you can go to the website and also click your specific state so you can get even more specific information. The resource centers are fantastic. They have a lot of good information. They have trainings. They have resources. They can help answer questions. Really, really useful. And then the ATA's Policy Center has really good information as well. And while that's good for states, what about countries? Well, there's not a lot of universally accepted places for this, but APA has a global psychology alliance. You can see a lot of the dots where you can click and it will give you contact information for different places. So it's not specifically telling you what to do, but it is a nice way to reach out to those places and ask about the laws and regulations. And even if they don't speak the language that you do, you can get translation services, AI, all that fun stuff to assist you with the process. Or obviously consult with people who do speak the language to be able to make sure you're getting a one-to-one translation. And I'm not a part of this, but I have had a lot of people tell me about the International Council of Psychologists. While not telehealth specific, apparently a lot of their discussions do in fact focus on cross-jurisdictional practice. So it's just a nice organization of people who can be able to help each other. All right, so now we're getting the tail end. So clinical best practices. So now we're getting to the clinical side of things versus the administrative side. Psychologists strive to incorporate best practices to ensure quality standards of care and telepsychology services align with standards for in-practice. This is probably the most straightforward ones. Make sure you are practicing in an evidence-based, evidence-informed manner. That's it. That means we apply the same ethical and professional standards that we do in person, and we are aware of the inherent limitations of telepsychology compared to in person. This includes gait, psychomotor agitation, and hygiene. Now, let me just say up front that all of these can potentially be overcome. You can have someone stand up and walk around. You can have someone zoom the camera out or sit further back so you can see more of their body. You can have multiple cameras. You can have collateral where part of the treatment, let's say for bariatrics or for eating disorders or for substance use, there has to be a collateral person you trust, and that could be going to a local clinic to get weight checks or substance use checks, blood work, hair samples, saliva samples, all that fun stuff. So, like I said, there are ways of overcoming some of these limitations, but doesn't just because there are doesn't mean you are specifically able to, or you want to put the effort into it, or it's just not worth it. So there are these questions that you need to ask yourself. On the application side, this means you need to know what the literature said. See a theme here? Again, beating the dead horse, I think, at this point. I'm going to kick it a few more times. That we need to know what tech works generally, for whom, what has been successfully translated to different services, and what has been adapted to these different services. So the tech, is it equally as good for assessment, for intervention? What about this specific test? What about that specific test? So how are we supposed to figure this out? Well, we need to know what the literature says. We need to know what the organizations say, excuse me. And if you're doing assessment, what do the publishers say? What do the publishers of the treatments say? What do the research groups say? What about the advocacy groups? What about the supervisors and the trainers? Like, what do those groups say? What do the accreditation standards say? So now there's no best way to do this because it's so broad. But when it comes to reading, because we already talked about the training and all that fun stuff, when it comes to the reading, I really like resources by the main standards. Obviously, there are many more, but we have our APAs, APA 1 and 2, I guess, our American Medical and our American Telemedicine. They have a lot of good resources. And again, there are lots of websites. I don't want to name any specifically because I know some are for profit and others, and I don't want to get in trouble. But there are organizations out there. There are certificate programs. There's a lot of them out there. They vary in terms of content. Some give you certificates, some don't. Some are by field experts, some are not. It really just depends on what you're looking at specifically. But if you were looking for a little bit of extra guidance on the journals, in addition to the general psychology and medical journals, JAMA and Lancet and Journal of Clinical Psych, Professional Psychology Research and Practice, so on, the American Psychologist, those kind of things. Some that I like, and I'm not endorsing any over the others, just so you know, the Journal of Technology and Behavioral Science, Digital Health, Journal of Telemedicine and Telecare, Journal of Telemedicine and eHealth, Nature Digital Medicine, Lancet Digital Health, and Frontier in Digital Health. Now, two caveats here. One, I publish in some of these, so obviously I'm biased, but I do like them because I think they have some good stuff. And disclaimer part 2, this goes along with my bio earlier, I actually helped form the Journal of Tech and Behavioral Science. I was part of the task force designed to help make it. We helped recruit our editor, Donald Hilty, who's a very big name telepsychiatrist. He's fantastic. He helps us run things. And I'm on the board, and I run the telecompetency and education and training column of that journal. So I am very clearly biased, but why I'm mentioning it is not just my bias. The reason I'm biased is because they don't just publish quantitative. They also have qualitative, and they have spec pieces. They have competency pieces. We publish a wide range, including how-to guides, competency guides, historical views. So we publish a wide range, implementation studies, reviews of how things were implementation and lesson learned. So it's not just a straight quantitative, even though we have a lot of that too. We have other sections for those non-quantitative, that application, because one of the biggest things we wanted to do was get that information out there and not just focus on the numbers. Like, what did you really learn? How can people take this and go use it? So I would encourage you to check it out if you haven't. But again, no pressure. But I really like it. And like I said, I like these other ones too. Some of the other ones do have some similar column areas, but again, a lot of them like their RCTs, their randomized control trials. They like their reviews. And sometimes those are harder to extrapolate real world practice implications versus what did the data say. And I think both are important. I think you need to have the data, and then I think you have to know how to interpret it and apply it. When it comes to telehealth appropriateness for patients, there's not a lot out there. These resources have some things, but I also wanted to point out two specifically because I've been asked about this a lot. I really like Peter Shore's ASH 25, Structured Guide for the Assessment and Suitability for Home-Based Telemental Health. It is not a normed assessment. It's a clinician-based interview, essentially, where you go through and you select 0 through 3 or 4, how the person did in the past and how you think they would do, and you can add it up and come to your number that you feel comfortable with or not. And it can help as a little bit more of, subjective objectivity, but it can help you get to where you need to go. And then in my book, again, not hawking it, it's just one of the only ones that has it. There's a whole series of checklists, including patient appropriateness, where it details many, many different factors that you can use as a checklist. So that brings us to testing and assessment. Psychologists are encouraged to consider the specific issues that may arise when conducting testing and assessment via telepsychology. So we talked a lot about treatment. Let's talk about assessment. This one is complicated because psychologists need to be aware of the impacts and limitations of the administration and interpretation of the telepsychology assessment, meaning we have to know about the tech, we have to know about the normative data, we have to know how it influences it and how it could influence the interpretation. We need to be aware how it could affect forensic, educational, organizational, consulting, or neuropsych practices. And this means we have to know about the challenges of assessing time tasks with accuracy. We have to know about the lag. What about the impacts of third-party monitoring during the assessment? Other people in the environment. We have to make sure the environment is set up appropriately. There might be cheating. Nowadays, we have AI and everything else that can answer questions for you, or we have someone in the room Googling while we're asking questions, or we have someone kind of coaching. We have to be careful of this and set up everything in a way so that we can tell as best as we can. Not all tests were based on normative data that was designed for digital administration. And what is the perceived reliability and validity by those commissioning? So in other words, will a court accept it, or is there going to be a bias against what you found because of reasons of doing it digitally, because it's not exactly as empirically sound? Or is it totally sound because you have enough to justify what you did? Going back to my statement of, I want to be able to justify everything I did, should I be asked? This means you need to be aware of the lag. Are there any delays? We need to know about the video quality. That includes the clarity and the font size. What about the angles? Like literally being able to see what I want to or zooming out. If I zoom out, I can't see facial expressions, maybe tears. If I zoom in, I can't see bouncing feet or writhing your hands off screen. Or when you put your pencil down or your pen. Audio quality. Remember, I said the microphone picks up everything. If you have someone in the next room who's being loud, it could pick that up. I cannot tell you how often I have kids playing in a different room when I'm talking to the parent and the patient, and I can't hear half of what they're talking about because I can hear Bluey blasting in the background. And I hear Bluey very well. I can watch the whole episode. That's not exactly helpful for me clinically. Lack of nonverbal observation is possible. Again, you can have multiple cameras or zoom out if you want to. And what about the patient's acceptance? If they don't like tech, that could also influence how they're responding. It doesn't have to be the testing itself. It could just be they're responding differently because they're uncomfortable, which we have to ask about. So in the real world, all of this is what we have to consider. The types of tests. Has the test been evaluated for digital administration, and what did it find? So many have been assessed, and then WPS, MHS, Pearson, and the lot, PAR, they've been publishing more and more that were either normed for telehealth administration, digital administration, or updating normative data. And this is aligning with individual researchers doing the same thing. And this has been going on for a long time. Cullum and Grosch did this over a decade ago. So we're finding new things. But not all assessments can be given administratively. So if you look at the publishing website of the ADOS, so the Autism Diagnostic Observation Schedule, it flat out says it is a social test and it is not appropriate for remote administration. Now, I'm not going to sit here and nitpick, as I know people still do it. What I'm saying is we cannot trust some of the outcomes for reasons. And again, I'm not going to go into those reasons right now. You can read the websites. But the publishers are saying it's too hard to control things. The integrity of the test is compromised in these situations. And again, that's not me. Don't shoot the messenger if you like the ADOS. I'm just saying it's not giving it in the way it was designed, and that could affect the interpretation and the outcomes. Latency and lag. If they talk very slow or freeze, is that because they talk very slow and they have cognitive delays, or they're freezing? Or if they stop writing, is that because they're thinking or they froze? So someone's like to have mid-assessment checks on the count of 3, put your finger up. 1, 2, 3, and they sit there like this for 10 minutes and they go, well, they could be slow, I guess, but usually it's because of the latency. the lag. Resolution. Sometimes we have to lower the resolution to get the speed better so it doesn't freeze, but something could be lost. Need for multiple cameras. I mentioned this a few times. I'm not talking about fancy. You can do this on a budget. If you have a laptop and a tablet, you can literally put the tablet straight up, angle the laptop down, and have each thing calls in as a separate user. So on my screen, I see two screens that are basically two different people from the two different tech, but I can see what I need to see. And again, there's more to it, but that's just the cameras. What can be missed digitally, we have to consider. Again, I mentioned some of these earlier. Gait, hygiene, smell is a big factor if we're working with certain populations. Agitation and hygiene, those are big. Disabilities, so are the delays, like I said, cognitive or physical? Okay. If they're screaming at me, is that because my volume is too low on their end and they think I can't hear them? Or is it diagnostic and they can't control their volume? Who's in the room? Can we pan the camera? Can we zoom out? Can we ensure the person's not taking a test like this? So, how are an apple and an orange are like? They go, clearly looking at somebody else. Cheating, we have to be clear and upfront. No screenshots, no screen capture, no AI assistant. Now, again, can you verify everything? No, you can't. But we can do our best to say we gave them instruction, they verbally consented, they consented on informed consent written. So if there's any question of that, we at least did our due diligence. I mentioned this one. Security of testing, like I said, don't record anything. Documentation we talked about. And then justifying it. I like having a statement on the validity of the assessment and the reliability. Can I trust what I found? If you want to know more, there's some good readings out there. I would encourage you to take a look at this. These are just some I like. They're not necessarily unique, and there's some more in your resource guide. And then really last two, because the last one is really very quick. Emergencies. Psychologists are encouraged to take reasonable steps to ensure the safety of individuals being provided telepsychology services and to establish the plans for potential emergencies or dangerous situations at the patient, client, service recipient's location. This means psychologists develop plans for remotely managing dangerous situations and or medical or psychiatric emergencies before providing the services or as early as possible in the services. This is different from in person where we usually are reactive because we don't know when someone's going to turn off the camera, walk away, get angry and slam the laptop or turn the tablet over. We want to have a plan up front to be able to have a security net. And it sounds stupid, but I can tell you it saved people's lives. I have people who say it's extra work, it's obnoxious. Not really. You can just give it as part of the intake packet. But it has saved lives, at least on our end. And unfortunately, there's no decompression period. When you leave an office, you have to drive home, take public transport. You have to transition back into your job or life. That's not necessarily true if you're connecting over a lunch, get up and go right back to work. Or you go right out into your family. So unfortunately, like I said, there's no decompression, which sometimes helps with those, people getting agitated and not being able to take the edge off. So this means you want to gather pertinent information up front and create a plan for if the tech works or it doesn't, and if you are available or you're not, and document it and provide a copy to everybody. This is a consolidation of the literature, as well as APA and others. These are the 9 points that they suggest for telepsychology. You want to establish phone numbers and addresses of where the people are and can be during the session specifically, and this might obviously change. Establish emergency contacts of the community. This means I want to know not just a collateral person, but also nearest medical center or police department. Now, some people say this is overly intrusive. I don't care. I can tell you it saved lives, and that is a contingency of working with me and people that I work with because we want to ensure safety. Yes, it is a little bit extra, but I want to ensure safety. If you're not willing to provide that, maybe it's not the best option. And I also want to know how far away the nearest medical center or police are in case of an emergency. And again, we can argue whether that's right or wrong, but like I said, from a safety perspective, we want to make sure we have that information. And I can tell you it's saved lives before. We want to establish the criteria for an emergency, good of the ED versus a write down, and we'll talk about it later. And we want to make the environment safe up front. Now, remove alcohol, remove weapons, ropes, chemicals, knives, all that stuff. I had a psychiatrist recently. Can you really confirm that from a distance? And I laughed and I said, can you ever confirm that if you say it in session? Are you ever, what was the last time you went to their house? If anything, you might be able to see some stuff on video in the background. So you do the best you can. Based on all this, you want to have a step-by-step plan of what to do if you are or are not available. It's after hours, you're on vacation, you're ill. Write it down and share it. Make sure everyone understands it. Give it to them and document they understood and agreed. This is an old example, a condensed example anyway, of one that we used to use that I made. We have our little spiel up front about this is telepsychology. Here's what we're offering and not. Here are the limits of confidentiality broadly. We have our general contact information for the patient. We have our collateral information for the other people, our nearest medical and police department. We have our emergency plan if there's no fear of harm to the patient or others, or well, if there are. And there's my little caveat under note. At any time, the provider can decide that telehealth service is no longer appropriate and as such may be terminated. If such an event occurs, the provider will provide alternative referral options should, we call it in person now, but should face-to-face treatment not be possible. And again, this isn't a bridge. There was a longer version that went into detail, but that's the idea that we want to make sure we're documenting. Education, training, and supervision. Psychologists providing supervision of or training in telepsychology, as well as those using telecommunication tech to provide supervision or training remotely, in other words, telesupervision, strive to be competent in the services they supervise and the technologies used. So if your head just exploded on what that means, what we're saying is that there are two different types of factors here. They overlap, but they are different. And this is where people confuse these because the literature basically blobs them together even though they're not, and this is a problem. There is supervision of telehealth, which is the supervision of telehealth-focused strategies, components, and competencies. In other words, you are teaching how to do telehealth. This can happen via telehealth or in person. Like, for example, my class that I taught in person sometimes and video other times. This is in contrast to telesupervision, which is the supervision of whatever from a distance using telecommunication. You could supervise telehealth, but you could also supervise in-person services. So for example, if I'm here and I'm supervising someone 9 hours away in rural areas anyway, and I'm just supervising how they use CBT in person with somebody, that is still considered telesupervision because I am providing supervision via telecommunications. I don't have to be supervising telehealth processes, okay? So putting that together, psychologists who provide these services need to be competent, right? They need to be aware of the changing laws, and that includes of telesupervision, the supervision of telehealth, because chances are you're probably doing a little bit of both, and the technologies themselves. So in a real-world application, training and basic clinical skills are essential. You need to know what to do and why. You need training in broad supervision models and skills like a Stoltenberg-McNeil or a Proctor or whatever you like. How to translate those skills to individual, and then how to translate the supervision skills into the digital. So my colleagues and I wrote a paper that's cited here. You can look at it if you like. It's a small little paper, but we looked at the literature and broke it down to 6 primary factors of clinical skills. So you supervise the application of the evidence-informed factors, teleetiquette, room setup, speech volume, dress, all that stuff. Interpersonal skills, how you communicate, how you pause, how you consult. Documentation, ethical and legal, including supervision of cross-state and legal. And then telehealth specific. Who is most appropriate for which telehealth modality or which tech is best for what person, under what circumstances, and how you adapt it for pathology as well as other factors. If you would like to know more on this, there's a big grid in the paper we wrote. It's right here. It breaks down and it has examples, so feel free to take a look at it. But one thing I do want to make mention of is that when you're supervising this telehealth, like you're supervising technology, you not only have to review and assess and provide feedback on the general clinical skills of the trainee, but also the technical factors and then the merging, the integration of the two before talking about next steps for future patients. That means you're going to need more time. There's no way to not change your supervision strategies if you're just doing all of this from what you were doing, meaning you either got to add more time or you have to start condensing to make it fit. Because if you're adding in the tech discussion, that could take some time, but you can also use the supervision to practice the tech and to practice the processes. And finally, emerging technologies. Psychologists strive to apply the same ethical, legal, and empirical considerations and rigor of these guidelines to any new technology used in psychological practice. In other words, and this was more my cynicism, if you take the word telepsychology and substitute in, say, apps, AI, virtual augmented extended, VR, AR, XR, wearable tech, remote monitoring, robotics, nanomachines, 90% of the guidelines remain the same. You still need informed consent, you still need data security, you still need X, Y, and Z. So that means that any new technology is based upon your competencies related to education, training, experience, so on and so forth. So that means with any new technology, you need to know what works for whom, strengths and weaknesses, ethical and legal, and knowledge of how to adapt it. Same thing we talked about, but this can apply well beyond just telepsychology. Because AI and VR are asked about a lot, I just put a couple resources in here for you guys. You can take a look at it later, but here's some resources. And finally, before we wrap up, I want to make mention. I heard this more than once. Are new guidelines really needed at this point? Don't people know what they're doing by now? And the answer is absolutely not. Maybe you guys do, but when you look at the research, a lot of people do not, because telehealth remains an example of you don't know what you don't know because you're not even sure what to ask because it hasn't happened yet. I work in a hospital. I probably know more than the average person about surgery, but once you get inside, I don't know where to go, what to do. I don't know what to ask specifically. It doesn't mean I can't learn. I was just never trained in it. And combined works by me and other people have found the same conclusion that the majority of people statistically, again, don't shoot the messenger, most people did self-reading and a 1 to 2 time 3-hour webinar. Most people learn by doing, and we equate this to the blind leading the blind to a certain extent. Now, while many have suggested beginning training in doctoral education, internship, and fellowship, as I mentioned earlier, unfortunately, it's starting, but it's still pretty rare. And what we found, we asked groups, and my group, among others, have actually asked graduate internship and fellowship what they're doing. Grad programs say our job is to train the basics. Internship and fellowship is where you get higher level stuff. Go learn it there. Internship is saying, our job is to push towards independence. You should already have this knowledge. And then fellowship is saying, we're specializing at this point. You should already know how to do the basics. So everyone's kind of pointing at each other. And yes, I like Spider-Man clearly. So the takeaway is we need your help. If you're in a position to be able to help disseminate these guidelines or help educate others, try to take the time to do it. It can be very, very helpful, not just for us, but for the field and the patients. So putting it all together, APA guidelines are meant as a starting place, not an end point, and we need to do our due diligence to remain up to date. So just some problem solving quick. How do I gain greater competence beyond what we talked about today? Here are some good papers. Here are some good guides. Here are some good books. If you want a consolidate of legal recommendations, I really like Epstein, Becker, and Green. They have a free app that you can go to. It just links out to other information, but you can see here I pulled the screenshot for DC. It'll tell you a lot of good information. It's a starting place. Again, you still have to read everything and do your due diligence, but it's a starting place. And then finally, is there any more information from our task force related to the 2024 guidelines? Yes, keep an eye out. We did submit a paper to expound upon some of these things. So stuff we couldn't include, including like we didn't want to include web links in the paper or in the guideline because they expire. But we wrote a paper. It is currently under review in American Psychologist. We hope to be accepted, no guarantees. This is the name of it if you wanted to keep an eye out. If not, we'll try to get it out somewhere else. But we do hope it's published, and it has a lot of resources. It's a little bit about what we talked about today with a lot more application and resources. It breaks down data security, informed consent, and it has additional web links that take you directly to good information. So with that said, I know that was dense. I hope you're still awake. Here are a lot of references, and here are my pets doing telehealth. So I am happy to take some questions should there be any. So thank you very much.
Thank you very much, Dr. Pearl, for that really informative webinar. And I'll have to say before I start with the Q&A, I'm enjoying your pets on the screen, so thank you for that too. I've tried to group questions into categories, so we'll move through that way. Let's start first with risk management. So the question is, given the constant evolution of technology, what's a practical way for clinicians to ensure ongoing ethical compliance when incorporating new tools like AI, VR, or wearable devices?
Yeah, so that is a loaded question. So the quick version, because that could be a talk unto itself.
Well,
If
I
I
will say
have
there were
some.
quite a few who asked that, variants of that. So maybe you spend as much time as you need on that one.
Okay. So first things first. Basically the same thing we talked about, just to be honest. So first things first, ethically, we want to make sure we know what we're doing. So there is a lot of research coming out on AI, wearables, those kind of things. So you want to make sure you are doing your due diligence to remain up to date on how they've been tested related to the efficacy and the effectiveness. So now obviously AI can overlay video and all that fun stuff, but you really want to make sure you have a knowledge of what works and you as a practitioner know how to use it, because the problem is AI is not AI. AI has been around for literally almost a century, and we've been using AI forever. So what does AI mean? What are you using it for? How are they using it? Microsoft Word is AI. Your phone is more powerful than most AI programs currently available on the market. So what is AI? How are you using it? So really breaking it down in terms of how you're using it and conducting a risk assessment. Part of having data security and doing that administrative side is having administrative officers who are keeping track of what you're using, why you're using it, what the limitations are, how it's being implemented, who's accessing it, are people accessing it, and then also conducting ongoing assessments. Some of the links I gave you should have information on that, including by NIST and NCOE, in terms of what you're looking for, whether you're using AI or wearable technology when it comes to those ethical and legal responsibilities that you need to cover, again, including data security. These includes encryption standards, of making sure the data is secure. Almost all the products, we would need a BAA in place to make sure, because most people are not creating their own AI program or their own video or their own wearable tech. You need to have the BAA in place. So, in addition to the research, in addition to the liability, you also want to look into liability coverage. As you know, when it comes to telehealth, most liability, malpractice covers, and I know the trust has a statement on their website, as do others. But when it comes to the use of AI and wearables and others that are not as tested and not as empirically supported, you want to check with your liability coverage to make sure that you are in fact covered, because you may or may not be, depending on what you have and how you're using it. And again, I don't want to speak for the insurance companies, but it really just depends on those factors. And then obviously you audit yourself. You keep track of what you're doing and how, and you continue with the continuing education specifically for those competency areas of what you're going to be doing. So in other words, if you already know what you're doing with AI, but you need to know more about the legality of it or the data security of it, you seek out those kind of training. So again, going back to my ultimate kind of thesis from earlier, if I ever have any issue and I get called into court or I have a legal issue, can I reasonably justify my practices in terms of what I did, how I self audit, what protections I have, what protections I made if I'm using third party companies, and I keep it up. And then finally, the obvious one is consulting. Consult with other people and seek some level of supervision. I don't mean necessarily like a school. I mean, if you're using something new, best practices according to the APA Code of Ethics suggest to consult and get some level of supervision. And you're never too old to learn something, and you're never too old to get some supervision. You might have to pay for it in some cases, but you can always look into those things. So that's kind of my long-winded short answer. If there's more specific things, I'm happy to talk about, but that's kind of my broad statement.
Well, what I will say, I love the plug that you gave for consultation. So I just want to remind folks on the call about our Advocate 800 service, especially for some of the more nuanced questions about use of these products and their given clinical situation. So our risk managers would be more than happy to talk through those. Let's move on to consent for treatment. How often do you need to renew the telepsychology consent with clients? This person's noting that they always ask a set of questions at the beginning of teletherapy sessions regarding their locale, confidentiality, comfort level with sharing information.
Mhm.
But how often do they need to review the actual consent form?
Yeah, no, it's a good question. There are no like universal standards. This is also going to vary by your organization, and your potential state, your jurisdiction of practice. Sometimes there are some regulations around this. Generally speaking, most of the time it's re-upped at least yearly, just to kind of review the processes, but it's going to vary by your population. If you're working with a population that have cognitive issues, you might want to do it a little bit more frequently. And quite frankly, we update them a little bit more frequently because like I work with children. We're coming up to the summer. People seem to forget that they travel over the summer. You can't connect from the Bahamas. Well, I guess, well, you know what I mean? You can't connect from an airplane to the Bahamas or on a cruise. Like there are regulations. So as far as getting written consent, like the full rigmarole, the document going through it, usually a lot of experts recommend once a year just to re-up it. Kind of going along with some of those insurance, you have to re-up some of those things every year. But it depends on your practice. Now, regardless, though, of whether you do the full rigmarole and the whole document, I agree with the way it was stated up front. Every session, I say, where are you? Any questions, any concerns, any tech issues? Let's address everything up front. And usually that takes all of 10 seconds. But if there are issues, that can help address things for the rest of the session versus just assuming, where are you? What's going on? Any issues, any changes, to any of the information we currently have, just to remind you, this is what it is. I like screen share. I'm lazy. I just put things up and be like, any changes to this. Now, I can tell you that where I work, we have a series of questions before you're allowed to connect. So we have some of this already built in, which I would encourage if you're able to. It saves me a headache of are you in the state? Are you doing this? Where are like it collects all that information before I come in. So all I have to do is ask the basic questions. So if you're able to do that or get a video platform that allows you to enter in fields and you can spit it out into a database, into a HIPAA compliant database, that could be very helpful. And while it wouldn't be a formal informed consent into the fullest extent, it can help give you that information in addition to doing it once a year. And then, of course, any new technology, any major change, you should probably redo the whole thing just to make sure you're on the same page. So if you're doing video based, but now we're adding it, this came up recently. We're doing an AI logger, which are they're good and they're bad ones. But anyway, it just listens to the entire session and writes an entire note. Well, that gets into some gray area of what do you do with that? And most people suggest that it's time to redo that whole informed consent process of a computer is going to be listening. We have a signed BAA in place, and you have to explain what that means in English. We have a signed agreement that everything is secure, it is private, but it will listen. And then if someone comes back and says, well, how do you know it's accurate? You have to be able to answer that.
Mhm. Yeah, I think that you anticipated a next question, which is about AI and documentation in terms of what your guidance is for practitioners who are considering use of those AI platforms for listening to sessions, just to be able to make documentation a bit easier.
Just to clarify, was it only about the auto logging or is it also about using AI for documentation in general?
Well, why don't we answer both? I think this one was just about listening to sessions, but I think both are relevant. And then I'll also just remind people that we have a presentation on AI and its clinical applications next Monday, May 5th.
Yes. And now that's really, really good because they can probably go into a lot more details of it because, like I said, AI is like saying I do medicine. There are so many applications. So anyway, let me go back. We actually have people here who use it and it's a double-edged sword. So this is just research wise. I'll give you two answers to this question. Research wise, the research is still very, very much out. Um, a lot of the companies that do these are not well tested. A lot of the quote unquote research is internal. It comes from their own people. And I can tell you, we have tested a lot of them. We have some neuropsychologists who have used them. And like I have yet to see any that really are great, to be honest, just as a general, like help me write the notes based on the data. So we're not talking about the auto loggers yet. I'll come back to that in a second. We're just talking about here's the data. write me a note, chat GPT, consolidate information, write a note that has these sections, and you write the whole thing up. A lot of them interpret, and you have to remember, AI has been heavily criticized depending on where it's pulling from. So if you're using, say, ChatGPT or one of those, it's only as good as the data pool it is pulling from that it is programmed from. Meaning, a lot of them use the internet, and we know the internet is a racist place. So in other words, there are many studies out there, and you can find them. In fact, I may have put some in my resource guide. If not, I have to find them. But we know that when you look at it, AI not only makes things up, but because it's pulling from things, it's been known to make racist and sexist comments quite a few times across a lot of platforms. So we have to be careful. So the short version is if I have to take the time to go through, and you should, if you're using AI of any kind, you should still review it. You can't just print it and go, here you go, because that's how people get in trouble. And if you don't trust me, Google, people have got in trouble for doing that, and you'll find a lot of stuff. If I have to take the time to go through and read everything anyway, did it really save me a whole ton of time versus just using Dragon Speak, or I can type very quickly, use smart phrases? So, me personally, I would love to do it, and I would love for it to learn from me. And you can make that, of course, but it's not quite there yet, in my opinion. And in most experts' opinion, it's not quite there yet. Now, maybe the speaker coming up may disagree with that, but I work a lot with the courts and I work a lot with the guiding organizations, and I think we will be there eventually. And the question is at that point, will insurance companies pay for the AI to write it? Because I think there's a new issue that arises of who am I actually paying? If you're not writing the report, why am I paying you for your time? And one part of the billable code is report writing. So I think it raises a whole new issue with that. Um, the AI logging programs are quite simply not there yet. I have yet to see any compelling evidence that they work super great, especially when it comes to jargon and that kind of stuff. I'm not saying they're bad. In fact, I'm working with a couple AI companies now. I'm working with one right now, where it actually I think it's quite good, but it's prone to errors, it's prone to misinterpretations. And just to give you an example, if you're bored, and I'm sure everyone in here has plenty of time, if you're bored, Google my chart AI issues. And my chart is the system that goes along with Epic. Epic is the largest electronic health record system in the United States. Most hospitals use it, most universities use it. It's very large and expansive. They implemented AI as part of my chart, which is the that's the messaging program. And you'll see there were lots of issues with people being told the wrong information. And it sounds like you, by the way. Like the issue was they thought they were talking to the doctor or the therapist or the nurse. And it sounded legit because it's learning from how I talk or other people how they talk. But it gave information on surgeries, people who didn't have surgeries. It told you to change your medicines when you shouldn't have because sometimes it pulled from the wrong database. It was pulling from everybody's or even under your own. It would tell you to do things that misinterpret the question. So again, do I think it could be helpful? Sure. I don't know if we're there yet. And as far as the logging programs, I keep getting sidetracked. Sorry, it's been a long day. A lot of organizations have standards around this. So if you're going to use it, you want to check with your organization because it's not as simple as just to do it. Some completely outlaw them. Others are okay. If you're in your own private practice and are looking to save time, my honest answer is if you're going to use it, make sure again you have your BAA, a very strong BAA in place because remember it is listening. Which you can argue the same thing, by the way, for Alexas and Dots and your telephone, by the way, your cell phone. So it's not, it's not unique. But I would have a BAA in place, update my informed consent, and quite frankly, I would test the heck out of it. I would take the time to use it and then read through the note and see what I would write and make sure it makes sense. And then, you do your own quality control. So, like I said, me personally, I'm not using it right now because every time we test it, we find a new issue. But if you are one to do it, I would at least test it enough to where you feel comfortable. And again, if I get called into court, did I feel comfortable enough to say that this AI program was validated and I tested it myself to the point of feeling comfortable and I documented it and I got additional training on using AI through the trust or otherwise. And like I said, I gave you some resources in here for AI specifically. So it's AI is not new, but studying AI is a little bit more new for the healthcare field. So we're not quite there yet, in my opinion. Other
Thank
people
you
may
for
disagree.
that.
Sure.
Yeah. Also, questions on data security. And so you gave several examples on how you could best get rid of data. One question is, how do you disintegrate your technological appliances to ensure folks in IT are not able to recover data?
No, it's an excellent question. So assuming you don't have, your IT team, most companies or you can seek out third-party companies that are unique to destroying like health technology. Like there are companies specifically designed to destroy health technology, and anyone worth their, you know, salt, so to speak. They have BAAs ready to go. They have the tech. They can walk you through the whole process, and a lot of places will come pick it up. So the way I equate it to, and this is a simplified example, I'm sure everyone has seen those shredder bins where they're the big garbage cans with a hole in the top and they're locked and everything. That's the idea where do you really know where it goes after this once it's hauled away? Like you sign the agreement, you make sure everything's in place, but you have to use a third party company because most hospitals or universities don't do it themselves. They ship it out. So that's what you do. You look for some of those companies, and again, you do your due diligence. If they're not willing to share that information, they're not willing to sign a BAA, you can argue the same thing for any tech you're going to use. If you have to hunt for it or it's not readily available, any company at this point knows what healthcare providers are looking for. And if it's not listed, they won't provide it, they won't sign things. In my opinion, you want to be a little bit wary about using them, at least in my opinion.
We also have a few questions about the clinical applications. And so one of them is, how might cultural considerations shift when providing telepsychology compared to in-person services?
Can you say that again?
Sure. How might cultural considerations shift when providing telepsychology compared to in-person services? Is there
Oh,
anything that people should be watching out for if they're making that transition?
no, that's an excellent question. The bad news is it is a woefully understudied area. I showed you some of the research. Everyone mentions diversity, DEI, culture, all that fun stuff. The problem is everyone mentions it without going into really any level of detail. And there was a paper that came out about a year ago that was talking about telehealth, clinical considerations for telehealth, as well as supervision and training. And they basically found that there wasn't much. So when it comes to that, what people have suggested is you do consider the same thing for in person, but you add in when you're using telehealth, what are their values? That includes culture, family values, tech values in terms of how do I like technology? What technology do I not like? Do I agree that the child should be on tech if you're talking to kids? Age related things. Should healthcare be done via technology at all? Because there are people who say no. Also, if you are working with a family, let's say, for example, I'm working with someone who is a patriarchy. How do I address people in the room? Do I start with a male? And how do I do that by a video? Do I specifically address them by their name or go, sir? But if I say, sir, do I know their identity? So I try to look up the names and I try to look it up and I just ask flat out. Like I like to learn. I tell people, listen, not trying to be rude. I want to make sure I do what is respectful to you. So how would you prefer we start this? Because if I'm meeting them for the first time, I don't necessarily know unless I have information up front, but how you address people, where you look, if there's certain cultures that look like eye contact or don't when they're speaking or listening, how do you do that with that telepresence we talked about? Different adaptations. Some people don't like that. Some people do. But I'm like I said, I'm not gonna lie, it is woefully understudied. I've been pushing some students to take a look at it. They're not going to. And it is something that we need to cover because everyone says you need to make adaptations for different things, but the 95% of the quote unquote diversity discussion are cognitive issues, so getting collateral people, hearing issues, getting hearing aids or extra headphones and devices, ocular issues, so high contrast modes or changing font size, that kind of stuff, or how you address from family set structures, like I said, matriarchy, patriarchy, that kind of stuff, and then changing the terminology you would use just like you would in person. But there are no, like, to my knowledge, really good guides on what to look at. It's kind of forthcoming. There are people who are studying it, but I haven't seen any really well-designed guides on how to do it. I've seen a lot of research on it that says it's needed and how we have to adapt, but I haven't seen a whole lot of things. And when I do read them, I'm always a little bit let down because, like I said earlier, they're generalities of tailor it to the specific language and the culture, use interpreters, learn to pause after. It's the same stuff you would do in person, and we haven't quite figured out. That's that infancy thing. We're still kind of getting up and running with it. So I apologize. I wish I had a much better answer, but I don't want to lie and just make things up either. I think it's just a work in progress.
Thank you. Probably have time for just one more question, a 60-second answer. This person says, I only work virtually at this point and stopped testing once I made the transition to all virtual care. What recommendations do you have for those for still wanting to do assessments virtually?
Okay, 60 seconds. It depends on what you quantify for assessments. Do you need rating scales that you can potentially digitize and host online? Or are they copyrighted? Do you have to get permission? Do they have online hosting? So a lot of the companies that sell it, so we use online hosted systems or rating scales all the time, where we can just send you an email and you can fill it out online, it auto scores and comes back to me. Or I can send it to you, you can print it, circle it, and send it back. If you're talking about, say, psychoeducational or neuropsych, that kind of stuff, that is a much larger answer. I would encourage you to take a look at the readings and the guidelines. I gave a whole bunch of assessment related stuff in the resource guide I gave you, but you got to consider a lot of stuff. Number one, looking into what the assessment is. Has it been translated for digital? Are there digital norms that you can pull from? How would you set up the environment? Are you testing them in their house? Are you testing them if they're at a local clinic? What about lag? How are you testing for that? How are you billing for? Like it's not it's a really really good question. I apologize, but it's not a 60-second answer.
Appreciate that. And we'll just remind people of the handouts that you gave in addition to the slides. Thank you very much for putting those together.